Good afternoon, everyone. Pleasure to have you all with us. We are having a wonderful workshop on psychology virtual conference. It's going to be very, very exciting and dealing about the mind and behavior and growing up and community and so many factors coming into play. So we're going to have a learning. We're going to have a learning and we're going to have some entertainment, I'm sure, and some fun. And at the end of the day, we're going to be saying that we're glad that we came. At this time, I'm going to hand over to Dr. Donald Gordon, who is the president of the Association of General Practitioners of Jamaica, to bring greetings.
Thank you very much, Aldit. Welcome once again. Welcome presenters, Dr. Shetty, Dr. Prescott, Dr. Livingstone, and Dr. Crossman. Well, Dr. Shetty is no stranger to us. He has presented to us on a number of occasions, so we welcome him back. Special welcome to Dr. Prescott, Dr. Livingstone, and Dr. Crossman, who I think will be presenting to us for the first time. A warm welcome from the association, and we eagerly look forward to your presentation. Good morning to moderators and session chair, Dr. Buckland and Dr. Notice. We are looking forward to seeing you chairing a wonderful session. We have to give a special welcome to our sponsors. We have Beatrice and Torrent Pharmaceutical. They are with us for the first time, and welcome on board, and we hope that you will come back to support us in the future. Special welcome to Medimpex, Indus Pharmaceutical, Abbott Nutritional, and Abbott International. They have been our faithful partners over the year, and they have given us tremendous support over the year. And without their support, I don't think we'll be able to function, with all the lockdown going on. Special welcome to the supporting cast. We have Dr. Swede, who will be doing the question and answer session, and Dr. Bidassi, who will give the vote of thanks later on, and also to Dr. Arlene Dawkins, who will lead us in prayers shortly. Last but not least, to our administrative staff, who is led by Lynn, who works unceasingly behind the screen to ensure everything is in place, and to Sam, our technical coordinator, who make things flow seamlessly. Special welcome to you, our audience. This is our final webinar for the year, and we welcome you back, and we welcome your loyal support, and we welcome also our members who have been supporting us loyally. This year 2021, has been a very stressful year, one challenging one, in which we have lost family, friends, colleagues, and we have had to give thanks to the Almighty for being able to survive this year. It is only fitting that with all the challenges and vicissitudes of 2021 we faced, we should end the year on a topic which addresses the challenges of COVID and our collective mental health. We are looking forward, going forward into next year. We hope to see you all, and we at AGPJ sincerely hope you'll have a safe, happy holiday, and we'll also wish the same sentiments for the upcoming year. We'll go over now to Dr. Henry Dawkins, who will lead us in prayer. Over to you, Dr. Dawkins.
Good afternoon, everyone. Let us bow our heads and place ourselves in reverence in the presence of God the Father, Jesus Christ, and the Holy Spirit. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so many blessings, and your presence continually reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today with your greatest inspiration, so that they may impart with clarity their knowledge and expertise to their respective topics. May we also absorb the invaluable information and experiences shared concerning the important issue of the mental health of our children and adolescents. And may we put into practice all we will learn today. We pray your blessings on all the committees in charge, that they may be able to fulfill their tasks responsibly, and that the objectives that were set may all be achieved. Bless the sponsors of this meeting, the moderators, the audiovisual administrator, that there may be an uninterrupted, smooth flow of all the presentations. Your infinite blessings will ensure the success of this conference. And may we be effective bearers of your genuine love as we use the knowledge acquired through this webinar today. We ask this in the precious name of Jesus Christ, our Lord and Savior. Amen.
Amen and amen. We've always heard that it takes a village to raise a child, haven't we? And the village is surrounded by villages, and there are rulers, and we have politics involved, the economies, and the whole of society. And all of these are playing an impact on an individual, especially a child and his family and her family. Now, Dr. Ganesh Shetty has been very, very involved in families and communities for a very long time. He's a naturalized Jamaican, and he's the only child and adolescent psychiatrist employed by the Kingston and St. Andrew Health Department, SERO, for the Ministry of Health and Wellness, Jamaica. He has worked at various child guidance clinics in the region. He's worked in schools and he's worked in communities. He's a consultant psychiatrist at the Medical Center of the University of Technology in Kingston, Jamaica, and has his private practice at Shekinah House, Seymour Park, which is off Old Hope Road, Kingston 6. Remember the security operations back in 2010 in the West Kingston section of Jamaica? A lot of violence, and the soldiers were going in and people were barricading themselves inside their area to keep soldiers out. But after the security operations in West Kingston in 2010, Dr. Shetty and his colleagues helped over 250 children of the affected communities who had post-traumatic stress disorder. Presently, in collaboration with NGOs, Dr. Shetty and his team trained and supervised the delivery of trauma treatment by youth workers in inner city communities of West Kingston. He also trained teachers at the elementary schools to assist traumatized children and their parents. That's what you call a visionary. He played a significant role in starting Saturday Clinic for sexually abused children of children's homes at the Comprehensive Health Center. After schools were closed in Jamaica to contain the spread of COVID-19, Dr. Shetty initiated and funded the Child and Adolescent Mental Health Project in the KSA, that's the Kingston and St. Andrew area, the child guidance clinics in this region, so as to reach affected youth and prevent unnecessary exposure to coronavirus. Also, he played a very crucial role in collaboration with the Ministry of Health and the Ministry of Education, with the support of UNICEF, to sustain this and expand the child and adolescent telemental health services to all child guidance clinics in Jamaica. Dr. Shetty studied at the University of the West Indies, getting his DM in psychiatry there, and a fellowship in child and adolescent psychiatry was obtained from the Department of Psychiatry, Dalhousie, University, Halifax, Canada. He has his Master in Public Health from the University of West Indies and a clinical fellowship in child and youth psychiatry, also from the UWI. He has a certificate in play therapy from the Canadian Association of Child and Play Therapy and a certificate in clinical supervision from the Northern Caribbean University and the Jamaican Psychological Society, and a certificate in trauma-informed care from the Traumatic Stress Institute, Kleinberg Family Centers. He has select research interests and has done many presentations and publications, including coping with COVID-19, helping our youth and tele-mental health. Another one was reducing adverse outcomes in adulthood, taking care of our children, which was a 2020 lecture series through the Western Region Mental Health Services in collaboration with the Department of Psychology, Sociology, and Social Work of the University of the West Indies. Other interests that he did, that he participated in, was a teacher training intervention on helping students cope with post-traumatic stress symptoms. And he did a workshop with the Association of General Practitioners of Jamaica in 2019, which was on violated and violent youth. And the Caribbean College of Family Physicians Mental Health Seminar in 2013 was on ADHD, substance abuse, and crime and violence. It is really indeed a pleasure to have this gentle giant come and present to us. Now, what is he presenting on? Let's see. Child, adolescent, and adult psychological, emotional, and behavioral aspects of COVID-19 in adolescents. Dr. Shetty, you're welcome very much to take the stage.
Thank you very much for your kind introduction, Dr. Buckland. Greetings, my brothers and sisters. One love, one heart, and one destiny. So we're going to look at what COVID has done to the mind, emotions, and behavior of our youth. And when we're talking about adolescents, we're talking about 500,000 children, 500,000, less than 19. And out of them, about 100,000 might have emotional behavior disorder, and about 25,000 might have a severe mental disorders. COVID already has infected 90,000 and killed more than 2,000 people. And this pandemic was superimposed on epidemic of crime and violence disorder, which I call CRIVID. A lot of distressing and depressing news comes out of newspaper on a daily basis. And when we look at what are the things which are fueling a lot of problems in our society, we find that poor parenting practices, poor psychosocial support, adverse childhood experiences, trauma, and unidentified and untreated mental disorders in youth play a big part, whether it is crime and violence, substance use, teenage pregnancy, child prostitutions, and such. And now, with superimposed COVID pandemic, there'll be increase in crime and violence, risk of more domestic violence and abuse. There'll be a lot of school dropouts or pause or lack of learning, and it might also make the existing risk of mental disorders worse. And we know that mind and body are connected, so that in turn might risk for diabetes, cancer, substance use, heart disease, and such. So it's not easy to be a teenager in Jamaica, because it's a time when we ask ourselves, who am I? Who wants me? Where do I belong? Am I white enough, black enough, fat enough, thin enough? Am I Christian enough or sexy enough? Which leader should I trust, and who are my role models? And when we hear about shatas in the newspaper, we think they're violent, but we need to understand how they are violated and turn so violent. Often the stories, they're unplanned and unwanted, disowned and abandoned, exposed to inappropriate TV and violent movie, abuse and neglect. Many of them could be barrel babies, and some of them are bounced around in care of uncaring relatives. Some of them might land upon streets work and live on streets, about 6,000 of them at least, and work in bars and go-go clubs. And when they can't take it anymore and act out, we label them uncontrollable and lock them up in so-called children's home or correctional facility. They are called crazy lazy at home and stupid dunce at school because they have a neurodevelopmental disorder like mental retardation, ADHD, or learning disorders. So they get ashamed and skip class and join their buddies under mango tree and smoke some weed and hold a medi. And sometimes that might lead to their brain playing tricks on them, delusions, hallucinations, psychosis can result. And some of them might be depressed, bipolar, can be triggered. There's no way to run from violence. It's at home, at school, community. Teachers and parents punish them still physically, and some of them might even develop post-traumatic stress disorder. Often they are caught in crossfire, even get murdered in a fake encounter, and they are begging before they get recruited by drug lord or area don and graduate from carrying guns in the school bag to a little gunman, fully trained to rape and kill mercilessly, before they become an unfortunate, emotionally dead youth unleashed on the society, before they die a violent death when killed by gangsters or police. Hopelessly, they are asking somebody, anybody, help. So how are we going to foster hope in this really hopeless environment, and how we can help them to live, love, learn, and laugh? And COVID gave me a little time to contemplate. We all know that race has disconnected us, religion has separated us, politics has divided us, and wealth has classified us. And it has led to a monetary, military, missionary, materialistic system. So we have to understand this hopelessness, or else we'll be hopelessly enslaved, believing that we are free. What are the factors fueling hopelessness? Education system which installs a lie that you're only as good as your grades, your future is only as bright as your grades, and this stresses them, and the boring online class is not working for many. Homework is still heavy, no mercy there, and this kills the creativity and encourages them to succumb to job slavery. Are we preparing them for the past or future? Look how we frighten them into action. In primary school, we tell them, if you don't do your homework, teacher will be upset. And when it's pep time, we say to them, if you don't do well, you go to dance school, and it continues. What we are doing is we are fostering a fixed mindset rather than growth mindset, where we think intelligence is something they're born with, and every exam, every test, they're supposed to show what they have. Whereas growth mindset is, you're born with a certain amount of intelligence, but more you work on it, better it gets. And the way to praise them is not that you are smart because you got this score. It's about, you got this score, you might have really worked hard. And when the goals are met, the person with a growth mindset would say, it's important for me to learn, whereas one from the fixed mindset is about how good I am, I must show everybody. And when they get into problems, they can stop and feel helpless, like one with a fixed mindset, whereas it should be actually resilient and face challenges and overcome them. We have a social system which entices you to get stressed and get addicted to drugs, alcohol, and now social media and video games, and keeps youth ignorant about how relationships work and what is it to be a parent. And we are also living in a monetary system which influences you to view as if everything is for sale and commodifies everything, including relationship. And we also live in a military system. The Don has a military, JDF has a military, and they fight with each other, killing a lot of innocent people in the process. And we are in a materialistic system which says what you possess is more important than who you are. What you drive is more important than what drives you. what is on you is more important than what is in you. And we also have missionary system in spite of many churches doing wonderful work and helping a lot of people emotionally and other ways. But we also have people masquerading as missionaries who exploit and even kill their followers. And the media doesn't do any good. It also fosters fear by headings like that. So what COVID has done to our teens? It has impacted their access to healthcare. They're afraid to come and catch COVID in clinics, and also many of the clinics have downsized and stuff, as well as mental health services were interrupted. We're trying to bring it back to the robust level it used to be. They're anxious, depressed, and they worry about their parents who take it out on them, their worries and stress. They're isolated and lonely, bored to death with online classes and everything except their friends they can chat with and have fun with. Sometimes they can be separated from families if there's quarantine. They're also afraid of somebody they love catching COVID and dying. And the family has reduced income, social isolation, and some child protection issues have cropped up. What COVID has shown is we are not alone. We are in this together. Each system interacts with other system, impacting the outcome. So schools, this is a recent study, and closure of schools, participation distance learning has affected their learning. It has been significantly negatively affecting what they do and how they learn. And there's a lot of increase in screen time. Supervision is not always available unless the mother can find somebody to look after them, maybe an older sibling when she goes to these jobs, which are temporary, and they don't give leave and no chance of working from home. They're having problem focusing, and that makes them not do their work, not get the grades. And of course, we have already, conditioned them to believe they're only as good as their grades. So they think they're worthless and start getting depressed and anxious. And some of them might lose their loved ones and might even develop post-traumatic stress, especially if they're close to them while they're dying out of shortness of breath. So they might have physical symptoms like headache, rashes. They may not eat well. They might be agitated or tired all the time. They might take risks, do drugs, and Skull School, which is online, is easy to do that. And how we can help them is to be patient, tolerant, and assuring them all the time. Keep the routine going to give some semblance of normalcy. And we have to create some new games, new family rituals, so that it can be bringing us closer as well as keeping them entertained. Telephone could be a tricky thing. It is only way they can interact with their friends, but at the same time, they can go on to many other things like porn or video games and get lost in it. Some of them might get depressed, and if you see them not eating well, sleeping well, not focusing well, have poor energy and appetite, and feeling guilty for no good reason. Worse, if they have depressed mood and anhedonia, and definitely if they have suicidal ideation, you know where to send them, emergency room. And some of them, as I said, could be having PTSD, whether it is pre-COVID or during COVID, and they might have flashback, nightmares, difficulty sleeping. They avoid conversations, activity, and people which remind them of traumatic event. They might be numb and detached, and they have a sense of foreshortened future. They don't think like others who plan to grow up, become something, have a family, and so on. They are not sure when their number can be called, and that's why they can become very careless and very numb. And they may not do well in school, and we need to get them help. or refer them appropriately to child guidance clinic or a private psychiatrist. So what these families need, especially weaklings from poor family households, as well as from vulnerable and volatile communities, they need security, biosecure protocols in school, financial support. They should get universal internet access, which is source of their learning, and parents should give some flexibility so that they can make arrangement for supervision, or else they will land up watching YouTube videos. They need a lot of support, as well as we have to be vigilant in their developing mental disorders. These are questions which every young person would like to be answered. Whether I'm safe, are you, the people caring for me, safe? How will this situation affect my daily life? And parents, before they can take care of the children, they should take care of themselves. That means eat, sleep, and move, exercise, and seek help if you are feeling very stressed and depressed. Although physical distance is helpful, but we have to connect socially more so now. And they can help the children then by being calm, proactive, stick to the normal routine, and allow the children to express themselves. So children should be seen, heard, and hugged. Check in with them what they're hearing, because there are a lot of negative information and fake news out there on social media particularly, and they might get swayed by it and become unnecessarily anxious. Create some new games. Have a dance competition with your daughter. Go out and play some badminton, or buy some cheap plastic ball which you can take for a football and not break any windows. And we have to watch our own behavior, because it will rub off on our children. And if we ourselves are very paranoid and depressed, that will not help them. And we mentioned this. So what are the ways to communicate with your teen? You have to build on your relationship. If your relationship already has been on rocks, then you have to use this opportunity to spend more time and build a good relationship with your team, which is family as well as the teen in it. And we have to show interest in what is important to them, rather than talk to them about what is interesting to us. And we can talk about ourselves, but not lecture them about our old-time glory. And see if we can watch some Netflix movies with them, although it might be boring for you sometimes, and ask what they think about certain issues which are out there trending, so that they can feel validated and feel more encouraged to talk to you. So becoming an active listener also is very important, to be engaged, caring, and non-judgmental. Show it in your body language, eye contact, what you say non-verbally as well as verbally. Ask some open-ended clarifying questions, and try to reframe what they said, mirror what your child is saying, so that they feel validated in having those feelings, right? And be ready when they're ready to talk to you. Don't force them to talk to you, because then that will make it more difficult for them, and you'll also in due course. And in terms of strategies for teens facing new normal, they have to recognize that their anxiety is completely normal. They don't become suddenly weak because they're feeling anxious, and they have to be helped to get some healthy distraction. We have to get some safe interaction going between them and others. For example, if both of them are coming from careful families and they're fully vaccinated, with appropriate precautions, I don't think why they cannot hang out in some place for a while. And of course, Zoom, WhatsApp video can also very help in keeping connections going, and be kind to them and help them to take care of themselves. And also we need to help them to keep themselves safe online. Be open about it, and use technology to protect venturing into unhealthy sites. Do some stuff with them online, maybe play a video game, and teach them what are healthy online habits, and also what do the online predators do to get them hooked and exploit them. But most importantly, it is time to change the mindset from fixed to growth mindset. We have to reframe so they don't feel terrible. Instead of saying, I'm stuck at home, it could say, I'm safe at home. Instead of saying, I lost all my freedom, it could say, I've given up my freedom for a good purpose, and so on. And you make a mistake, don't say I'm in a mess, just say I'm human. All the things are difficult sometimes. You can say, I can do hard things, and so on. And teachers should treat the students with a little more compassion, particularly now, if they make a mistake or don't return their homework on time. Don't be too draconian with them. Understand that they are going through a lot of stress, like some of you might be going through who are naive to the technology and so on. And make things interactive and fun. It should be joyful learning, not painful homework doing. And parents should send a message that you're a developing person and I'm interested in your development. And I'm not going to judge you by your grades, but I'll help you to do well and learn better. And when they do well, you don't praise them for the outcome, like you're smart, you're great, but tell them you really worked hard for this. And you see, once you work on something and focus, things will always land up being good. And we need to communicate what is important. We have to tell them not to focus on their gadgets, iPhone, latest television, because any of them can break on impact or become obsolete in no time. Focus on job too much also is difficult in nowadays because it can be lost or might turn boring and become unbearable sometimes. Even professions may decrease in demand and collapse under fierce competition or become redundant, and we all retire from it one day. Business can do very well or might also go down. So we have to really focus on what is important, not the cute car, not the pretty house. And we have to retrain them to think that they are more than their grades. They're not just as good as their grades. And there's more to their future, not just their future is not just as bright as their grade. And we have to tell them that they should not be undermined by rejection or conditioned by critical evaluation of others, or perplexed by cultural expectations, or perturbed by societal norm, or perverted by religious or racial prejudice, or confused by misleading media messages, or conned by political propaganda or fanatic ideology. And we have to tell them you're not just your looks, because everybody changes with time, and that sense of abandonment or feeling of being dumped when somebody you care about leaves you will not devastate you, where you focus on your soul and your mind and your spirit. And you have to tell them definitely you're not a devil of depression cursing you as unlovable and urging to kill yourself. We also have to tell them that they're not the anxiety arising from confused fear center of the bewildered brain. And we have to make them know that they're more than their body, because the body can risk putting on weight and losing weight, being lusted after and then neglected and abused, can collect scars if injured, or contact disease if expected to infectious agents. And there are no damaged goods, and they are not obliged to carry any emotional baggage. Then youth will hopefully focus on redefining themselves in a way that is free from what their well-washed, mal-conditioned brain is telling them, and in a way that identifies the unlimited potential of just being human offers. They'll use their new awareness of their real worth to free their brain from darkness of depression and terror of anxiety, and should be able to fully enjoy the excitement of learning and fun of putting real effort to master the information. And when that happens, for a student, examination becomes an opportunity to know what you know and know what you don't know, so you can know what it going forward if you need to. So it is not a slaughterhouse and you're not a lamb being dragged to the slaughterhouse. And for teachers, teaching becomes an opportunity to inspire students to a joyful learning, and examination becomes an opportunity to know what the students know what the students don't know, so they can teach them in a way they understand and remember better going forward. So examination is not a judgment on the child's intelligence or commitment to working. Then teen may say, I'm the mind which manages flow of energy and information from outside and inside to the body and brain. I'm the spirit which energizes everything, the soul which was in the beginning, the metamorphic manifestation of evolutionary impulse of this mystifying universe, a marvelous machine invented by unseen scientists, the magnificent piece of art created by invisible artists. And they will see themselves an incredible gift which is mysteriously wrapped and hopefully eventually will be gloriously unwrapped, and they will be humbly grateful as awesome human beings. And life then becomes an opportunity to discover and develop gifts that is mysteriously wrapped, and an adventure to experience home of health and happiness, and an opportunity to live, love, laugh, learn, and leave a legacy. But it's for all of us. If you don't play, you will pay. The opposite of play is not work, it is depression. I had to go virtual even with my playroom, and I do my virtual walks. I can take a walk on the beach, even when the beaches are closed. And dancing is very relaxing. You can do it. The first responders are doing it. Nurses need to do it also. They're so stressed taking care of so many poor patients. And the doctors. Even the clergy can take it easy and move and relax in the difficult times. And then definitely you can compete with your children, and it will be a fun time. Then horrifying time of COVID-19. And you might ask what is being done. Ministry of Health and Wellness is reinstituting telemental health, which has stopped for a little while now. And they're also planning on training, and there are some helplines. I'm going to give some helplines quickly. And Ministry of Education has some bunch of activities they want to put in school, which will help the children and the teachers to relax and find some semblance of normalcy. And they also have something called school-wide positive behavior intervention support, which is waiting to be expanded and upscaled. And Ministry of National Security is embarking on a citizen security project program plan, which should target the children who are on their way to becoming shooters and gunmen. And Ministry of Justice has child diversion program, which will give an opportunity for non-violent crimes committed by children to get counseling and get rehabilitated rather than put in children's jail. And of course, we also have a drug court where the folks who are committed drug-related offense will get a chance of rehabilitation. And these are the hotline numbers. And there's a new one called Safe Spot. That's the number there. And you can even WhatsApp them, which teenagers like to do a lot, FaceTime, and even connect with them via Instagram, Snapchat at Safe Spot JA. And there are some other numbers. And one rule of thumb is your nearest mental health or child guidance clinic could be either inside your type 5 health center or hospital, or at least you can be guided from there where it is located, and you can refer them. And also there are psychiatrists who do see children and help adolescents too. So colleagues, this is definitely a crisis which has gone on for almost 2 years now. It's dangerous, but also it is a tremendous opportunity, and this is a tremendous crisis to waste. And if we can work together, we can succeed together because we are all in this together. We've got to be part of the solution, not part of the problem. And when you do that, better must come. Thank you.
Dr. Shetty, thank you so much for that wonderful presentation. It is quite an eye-opener about the issues that are present and the solutions that we are going for. We need to grab the solutions and work through the interventions to get to them. Because if we focus on problems, we'll always have problems. And we know that that the society, there's just a lot of mess everywhere. However, I think if each one of us in our communities, through our own connections, will work together so that we plant human gardens. We can plant human gardens. We can plant human gardens that will have some peace, like peace of mind. I said peace, but it's like peace of mind, peace of heart, and peace of soul. We could have also in the garden, we could have squash, could squash the gossip, because there's a lot of gossip on social media. So I think we should, engage our children in this, to squash the gossip, squash the indifference, squash the grumbling, squash the selfishness. And also in the garden, so apart from peas, we have squash, lettuce. So lettuce, we're going to say let us be faithful, let us be kind, let us be patient, and let us really love one another. And what is it to love one another? LOVE means really, L is really listen. Dr. Shetty is speaking about listening. O, overlook. We must learn how to forgive. And it's really not a feeling, it's just a choice. So we need to know it's a choice. Overlook. And V, voice encouraging words, just as Dr. Shetty said. Because without encouragement, there's really no growth. And E, we know it takes effort. It takes effort to care. So listen, overlook, voice encouraging words, and it really takes effort. So in the garden, we have our peas, our squash, our lettuce, and then we need to water with patience, cultivate with love, because then we get much fruit in the garden because you reap what you sow. And remember that no garden is perfect unless we have some turnips. The turnips are really turn up for your meetings, turn up for school, turn up for service to your, whatever you do at school, whatever we do, because we are serving. It's when we actually surrender our free time so that we can serve others that we're going to soar as a nation. So we surrender, then we serve, and then we soar. We just see everything just really falling into place. We can start from our own family, go on to the community. So we turn up for meetings, we turn up for service, and we turn up to help one another. Dr. Shetty, it was a pleasure to hear you. Thank you so much for sharing.
Thank you, Dr. Buckman. I'm very impressed with your garden. Can I borrow it for my next presentation?
I will type it for you and send it.
Thank you very much.
If anything, what I'll do is to send it, I'll type it up and send it in the chat so people can benefit. When you're talking, I said, where's that thing with the garden? Let me look in my bag. So it was in my bag. So to the peas, which is peas, the squash, the lettuce, and the patience, and turning up. Because unless we turn up, nothing happens in the country. Because we're going to think, oh, somebody else will do it, but really nobody does. So can we be the someone who turns up and serve? All right, Dr. Peter Swavey, over to you.
Thank you, Aldith. Much appreciated, Dr. Shetty. Your presentation was very much appreciated. If you look at all the comments in the chat, it really demonstrates that other people were very impressed with your graphics, and my wife was impressed with your knowledge of the latest dances that are going around. So we have a few questions for you, and I'm going to ask to share my screen. And let's see, hopefully you're seeing that. And here we go. So the first question, please comment specifically on the effect of social media and what are your suggestions?
Okay. First is permission to be on social media. We have to really think, is it really wise or helpful to allow our 13-year-olds, 11-year-olds to be on social media? Because there are so many people pretending to be somebody else who are specifically targeting younger, innocent kids. And even if you're on the social media, this will not be popular with teenagers, but although you're not going to check every posting, every movement they make on it, but they should have a level of trust where you can, with them, check what's happening in the social spheres, because a lot of bullying also can happen in social spheres. And recent research, which was hidden by Facebook, showed it has particularly affected a lot of teenage girls negatively because there's a lot of comparison. And there's somehow this belief that a lot of stuff which comes in social media is true. I mean, you can always Photoshop. I can Photoshop and look like one of those Mr. Universe bodybuilders, and a lot of it is fake. And there's this almost fetish to represent themselves in better colors, although it's not true. So that can make other children, one, feel inferior about themselves, two, get influenced by it. Okay, they are doing it. I saw my friend having a glass which looks like he's drinking wine, so why should I not? So it can be, but also it can be source of good in that, especially now when the social life of the teenagers have been really decimated. That could be only way they can socialize and support and seek support from their friends and so on. And some of my patients between the sessions get help through social media from their friends and family too from elsewhere. So good and bad. So we need to moderate the age as well as access and also the duration they might be on it, because there are always so many postings happening all the time. And if we, me myself, had to be careful how many WhatsApp messages I see every day, or else I could spend a lot of time, which will take away my time from something more important. That can happen to teenagers too. So social media can be good, but also it can be source of a lot of bullying, jealousy, and induced sense of inferiority also.
Okay, great. Thank you so much. That's comprehensive. And this is from Dr. Gaynor Dono. What strategies can we use to get children out of their room and integrate into the family event, helping with chores, etc.?
Okay. If it is going to start during COVID, it's not going to work. It has to be from the very beginning. Maybe even when they are preschoolers, we can get them involved. Even if we have helpers, help them to make bed as soon as they can do it, and do some of the simple things for themselves to helping out, at least during weekends. Weekdays, they are swamped with homework. And it should be a gradual process so it doesn't look like a chore and typically research shows that every parent has to spend 20 minutes per child per day. Of course, you can leave a larger chunk of that time for weekend, but that's what it says. In other words, you are in touch with your family, all members of the family, including the teenager, on a daily basis, and you share things, you appreciate things, you joke about things, and that, I think, is rapidly going. Everybody's locked up in their room, doing their own thing. They have their TV in their own room, and of course, they have their smartphone everywhere they go. I don't know if it's a smart thing to do. So it has to be a gradual process, and way to draw them out is find something interesting for them to. If you're going to call them out and lecture them about the homework, you know what's going to happen. They're going to go and bang the door and lock themselves inside. But play some ping pong if it's raining outside in the house. Play some that shuttlecock badminton, which is not going to break any windows. And have some dancing competition. You saw how nurses were dancing in the video clip. You can get some inspiration from it. And don't make chores boring. I mean, dishwashing sometimes is most disliked chore, and you can demonstrate, how dishwashing can be so relaxing. That's feeling of the soap on the hand, that is nice smell, the water flowing, the sound of water flowing. So reframe, make it look interesting rather than you yourself, you're complaining about the work you're doing, then of course that'll rub off on them too.
Thank you, Dr. Shetty. I've gained a new appreciation for dishwashing. The next question is, well, one of our participants is asking if she can get a version of this mental health presentation. I guess that you can discuss that with our
Sure, I have sent a PDF version already to the our IT folks, and they can be shared with anybody who's interested. No problem.
Wonderful. Thank you so much. And another question, could the list of crisis center numbers be left with the AGP office or sent out as well? Well, it's in your presentation, right?
It is. It is one of this last, but one slide, I think. So you can just copy it and send it to folks. Okay,
fantastic. All right. I think we have one more question here. It says, my teenager smoked ganja in high school. I gave him a flogging. He resented me for that. He never said he was sorry for smoking, but I need to apologize to him seriously. I'm yet to do so now, and he has distanced himself. I guess the question is, what's the best way to restore that relationship?
Get somebody to mediate the reconciliation. Maybe it's the mom, maybe it's the dad, maybe it's the grandfather. So even though he might refuse to come with you, have a family outing. Even though he might hate to come with you, might want to hang out with his granddad, for example, and doing something which he'll not think boring. So, and at some point, you got to do what you got to do. Although he may not, he might be surprised. My parent is apologizing to me. This is strange. But make him know what happened at that moment, how your emotional center took over your thinking center, and you did something which was not helpful and actually was harmful to your relationship with your child. And give him some time. Although some of my patients tell me when they're leaving, because they're dragged to me by their parent, teenagers particularly, Dr. Shetty, don't expect I'll come back in now. Bye-bye. But somehow they come back after a few weeks. It's a process. Don't get disappointed. You don't get the reaction you hope for right away.
Okay. We have another question. What techniques can be used to reduce anxiety for teenagers?
Okay. There can be no better simple technique to deep breathing. Take a deep breath in through the nose on the count of 5 and out through the mouth for the count of 5. You can do it any number of times, any number of frequency per day. It looks too simple to be helpful, but indeed it is one of the most helpful. And other one is you could do progressive muscular relaxation. You Google it, you can get a lot of scripts for it. And visualization also can help. I mean, all they're stuck in the house, you can take virtual walks or take virtual beach visits, as well as you can think about place you want to go once COVID kind of subsides. And doing fun things like video games, not too much, or dancing competition, that could relieve some anxiety.
Very good, very good. I think we are at the end of our questions. Thank you so much for a wonderful presentation, and also your dedication to our teenagers and your understanding of them. It's very obvious that you have a very good handle on where teens are at. I don't think that's just because of your profession. So thank you.
Thank you
Over
very
to
much,
you.
Dr. Sweeney. Appreciate it. And
All
thank
right.
you, Dr. Gordon, for inviting me.
Okay. Over to you, Olive.
Dr. Buckland, are you there? You're muted. Oh, there you are.
Got it. Yes, thank you. Everything in good time. Can you hear me now?
Yes, perfect.
Okay, and you can see me. Okay. At this time, we welcome Upjohn Pharmaceuticals to present on something that they want us to know about. So Upjohn, your turn.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
That's it for Upjohn Viatris.
Okay, thank you very much, Sam. Our next sponsor is Abbott International, and they now have the platform.
Okay. Good afternoon, everybody. Can you see my screen? Wait, am I unmuted?
You're unmuted, but we're not seeing your screen yet, Kelly.
Oh, where is it going? Little it. Share content. Whiteboard.
No, you should be at basic and then you should be sharing screen.
Zoom start broadcast. Okay, should be going on now.
Yes, start broadcast. Touch it again once more. There you go. So
Okay.
you can now go to your home menu button and go to what you want to share.
Okay.
There you go.
I see.
Life to the fullest.
Yeah. Okay. Good afternoon, everybody at AGP. Thank you for having me. It's been a while. For those who don't remember me, it's Kelly Anshin. We're in a COVID time. Things are, look at what Dr. Shetty was showing, we need a life in balance. And one thing with Abbott is that where it comes to our neuroscience portfolio, we have a very extensive portfolio. So in terms of neuroscience, I just like to remind you of certain products that we have. The Depakote ER, which is once a day, the Depakine valproic acid, and the Depakote, which is the divalproic sodium, which is twice a day, and your Depakote ER, which is once a day. Okay. As you know, we have been in the neuroscience business from 1900s to 2021 now with these classic products. And what we'd like to do to show you that we have a solution for every type of patient. The Depakote is a unique product because it's a 3-in-1 product where you actually can use it for epilepsy of any type, etiology. And also you can use it for manic episodes associated with bipolar disorders, or and its first line for mood stabilization. Okay. And also for prophylaxis for migraine prevention, something that is very common in Jamaica. And even probably more so now. And with the prophylaxis of migraine prevention, it actually helps to reduce the duration, severity, and frequency of the migraine attack. So as you know, it's a patient-inspired solution for your patient. And of course, with the Depakote and Depakote ER, the divalproic sodium is a combination of valproic acid and sodium valproate in a 1-to-1 ratio to give you that divalproic sodium. And it comes in 250 milligram and 500 milligram tablets. And as I just remind you, bipolar disorder, manic episodes, epilepsy, and prophylaxis for migraine. Okay. Something that I'll also touch on, since we're looking at the whole mental health, when you have abnormal TSH that might be due to an under-treatment of hypothyroidism, you'll find that you might get mental impairment, decreased concentration, and depression. These are symptoms that are associated with hypothyroidism. So in a case like that, I would like to remind all of you of Synthroid, levothyroxine sodium, which gives you precision and consistency in every dose. And you can use it for your versatility for the myriad of patients that you may have, from babies, pregnant mothers, teenagers, all the way to the elderly. Okay. It is a golden standard treatment for hypothyroidism. It's one of the most prescribed in the States. And of course, it has over 60 years of global clinical experience. And we have 9 presentations for greater precision and dosing in Jamaica, going from 25, 50, 75, 88, 100, 112, 125, 150, and 200. Okay. Right. So again, it's indicated for the replacement or supplemental therapy in congenital and acquired hypothyroidism of any etiology. And of course, working in that narrow therapeutic range, it gives you the precision and consistency that you need as such. Now, this is a new kid on the block. And I know everybody is familiar with probiotics. Well, we have another one here for you now. It's called BioGaia, Lactobacillus reuteri protectis. And I emphasize the protectis very much. It's actually drops. It's in a 5 ml bottle, which has 20 days of therapy, and it covers colic, infant colic, regurgitation, abdominal pain, which is associated with functional gastrointestinal disorders, constipation, and diarrhea. And like I said, it's just 5 drops once a day. What makes it different from the current probiotic that's on the market is that where you would use that one twice a day, and it only has 4 billion CFU units, BioGaia has 10 billion, and you only have to use it once a day, all containing that 5 drops that you would use once a day. Okay, and it's derived from human breast milk. So it will give you the efficacy that needed for your patient, right? In terms, it's a useful nutritional supplement for both in terms of the colic, diarrhea. It's flavorless. It can be used simultaneously with antibiotic and other medications, and it can be used for newborns and premature babies. But importantly, it can be used from age 0 to 100 plus, right? And you just shake the bottle, turn it 90 degrees, and just count 1, 2, 3, 4, 5 drops, and that's it for the day. I am testimony for that because I use it. I had used, well, I am on it still, but I use it for in terms of my reflux as such. Okay, and you can use it in juice, water, milk, or in foods, but not in hot foods or hot drink. Okay, and it's available in most pharmacies, well, in pharmacies, and it's also over the counter. We are actually working to get a little insurance, to get it under insurance as well for your patient. But it's very convenient and very cost effective for the whole family. So it's there for the whole family to utilize. Okay. And since we are coming into the respiratory season, I would like all of us to take a closer look at Claritin. Discover, rediscover, and discover the benefits in respiratory tract infection. Right, because it's the only macrolide that actually has a bioactive metabolite, 14-hydroxy clarithromycin, which adds to the efficacy and efficiency that it works with respiratory infections. Sorry about the plate. As such, in vivo, and of course, indicated for upper, lower respiratory tract infections, soft tissue and skin infections, and for the eradication of H. pylori. Very good in terms of using for community-acquired pneumonias, which you'll see quite a lot more of these days. It has a high bactericidal concentration in your serum, lung tissue, alveolar macrophages, and epithelial lining fluid. Anti-inflammatory mucolytic activity, which is well needed now more than ever when you're dealing with respiratory infections. And the pediatric suspension needs no refrigeration. So as you can see, we have the XL 500 XL, which is once a day, your Claritin 500, which we tend twice a day, which we tend to use for H. pylori eradication, and the pediatric dosing, 125 in 5 ml and 250 in 5 ml. Okay. Now I sent out an invitation to all my doctors in terms of the A-Care, and if you have received this certificate of attendance, what I will ask of you, if you could please send it to either myself, a copy of it either to my email, a copy of it to myself, or to Lynette at CCFP and AGP, so that we can add the CCF logo onto it, so that you will be able to get your 7 credits that was given for this particular conference. And just to let you know, in case you want to reach me, your Abbott pharmaceutical representative, which you can contact me 24/7, I don't mind, right? My number is 818-4793, and it's also my WhatsApp number and my email, okay? Please do not forget the E, right? So it's kellyann.chin@abbott.com, okay? So it's been a pleasure being here with you. I wish for you to have a wonderful day, because right now I'm very interested in all the so far with the topics. And so let's continue, and thank you for the time that you've had. So any questions, please let me know.
Thank you. Thank you very much, Kellyann. Very interesting set of products from both Abbott and Upjohn. You know, friends, straight in my eyes. Look me straight in my eyes. Life's short enough. Life is so short. So guess what? Let us just be kind to each other, kind to people, because we just do not know how long we have to live or they have to live. So if there's somebody you want to reach out to, just reach out. It doesn't matter, just reach out. It just takes your effort to say, call up and say, whatever you want to say, just reach out. Life is very short. So let's just appreciate each other and appreciate life. You don't know about tomorrow, we know about now. That's all I have to say. And the other thing is that My model of the world is different from your model of the world. Each one of us have our own map of the world. So my map of the world is different from Sam's, different from Donald's, different from Peter, because I have some events just like you coming into my headspace, but I'm going to filter it different from you depending on what my current attitude is, what my current beliefs are, my value systems, my past decisions. So many things is filtering through. So I'm going to arrive at a decision that may not even be like yours because of where I'm currently at. So I think we need to actually respect each other and have a conversation, all right? Because people, and you're going to also have people process differently. You see somebody, you cannot assume that they're processing like you. Isn't that right, Dr. Shetty? Of course, I'm going to say, you're going to say yes. We all process differently. All right, our next speaker is going to be speaking on something really, really interesting, which shows you about how we process so differently. Psychological roots of vaccine hesitancy and resistance. Presenting this topic is Dr. Patricia Prescott. She has her doctorate in psychology and she's a certified cognitive therapist and clinical psychologist. More about her. Let me tell you more about this lady. So she's a psychologist and clinical director of the Caribbean Center of Cognitive Behavior Therapy and managing director of Breakout Spaces. She did her undergraduate degree in psychiatry and obtained her doctoral degree in clinical psychology from the University of the West Indies. She read for her master's in forensic psychology at John Jay College of Criminal Justice, the City University of New York group of universities. She learned cognitive therapy at Beck Institute and was designated certified in cognitive therapy by the Academy of Cognitive Therapy. Currently, she is the only psychologist in the English-speaking Caribbean community to achieve this level of certification in cognitive therapy. Also at the Beck Institute, she did training for treatment of anxiety disorders, depression, personality disorders, and use of meditation to treat worry, rumination, and thought suppression. She also trained in mental health treatment of obsessive compulsive disorder, dialectical behavior therapy, and this was done via a course offered by Massachusetts General Hospital Academy and Marsha Linehan. Additionally to the psychotherapy, she works with medical professionals in reproductive medicine, providing psychological assessments to recipients of third-party assisted reproductive techniques. She's a full member of the Jamaica Psychology Society, American Psychological Association, American Society for Reproductive Medicine, Academy of Cognitive Therapy, and licensed to practice as a clinical psychologist in Jamaica. Her company Breakout Spaces offers psychologists, psychiatrists, lawyers, life coaches, private meeting spaces to have sensitive conversations with their clients. Prior to her full-time private practice, she served the university community for 9 years as a sessional psychologist at the University of West Indies Health Center Counseling Unit. She also worked with the Faculty of Medical Sciences, Department of Health and Psychiatry as consultant psychologist. She is married and a mother of 1 child. She comes with all her wealth of experience and is here to present on a very, very interesting topic, psychological roots of vaccine hesitancy and resistance. Dr. Prescott, you have the floor.
Good afternoon, everyone. I am so glad to be here. When Dr. Gordon asked me to do this presentation, I jumped at the opportunity because it's been something I've been thinking about for a long time. So where do I start? Well, as you know, my title of my presentation is the psychological roots of vaccine hesitancy and resistance. And we're going to be looking at the concept of cognitive heuristics and biases. So let me just move this. we'll start with a definition of vaccine hesitancy. Vaccine hesitancy refers to the delay in acceptance or refusal of vaccination despite the availability of vaccination services. And this is a complex process. This is a complex concept. And hesitancy can vary across time, places, and with vaccines. And we're particularly talking about vaccines now because so many people who have taken vaccines in their life are now hesitant about the COVID vaccine. They've acquired this vaccine hesitancy during this pandemic. And it can be influenced by factors such as complacency, convenience, and confidence. So what I want to do before I start looking at the model, I wanted to say a little more about the person who is, or the persons, Jane and John Doe, who are more likely to be vaccine hesitant. And I was looking for some information, maybe on a Jamaican profile, but I found more likely what we found an American profile. And the Department of Health and Human Services found that the vaccine hesitant person is more likely to be between the ages of 25 and 39 years old. It is equally distributed among male and females. They're more generally skilled laborers with some maybe community college level or technical training, but they're usually without a college education. These persons usually state that 50% cite that safety concerns about being hesitant to take the vaccine. There are concerns about the vaccine. 20% said they didn't think they need to take the vaccine. And another 30% didn't trust the vaccine or the persons who develop or distribute the vaccine. And the study also found that over time, because the study was conducted between January and March 2021, they found that there was some improvement and some reduction in the vaccine hesitancy in those months between January and March 2021. The hesitancy, the biggest movers were for the Black American population. They became less hesitant and their vaccination numbers increased significantly. That's the biggest group. But for those who believe they didn't need the vaccine in any at all, that group increased. So that is John and Jane Doe, 25 to 39-year-old man or woman. And
all right, Dr. Prescott.
Yes, please.
Can you go to full screen on your presentation?
Full screen. Okay, sorry. Sorry, so just a second. This thing is full screen. View presentation slideshow. Okay, sorry about that.
Perfect, thank you.
All right. So did you guys get the rest of that though? Do I need to repeat that?
Yes, we got it.
Okay. All right, sorry about that. So I gave you an idea of the characteristics, the profile of a person, at least the American profile of someone who would be vaccine hesitant. I am not sure if there's a lot of variance with a more Jamaican or Caribbean profile. Although based on what I read in the newspapers, you know, and the commentary in the social media, a lot of those reasons that they identified in this study in America are similar, are the same that people give for their own vaccine hesitancy in Jamaica and the wider Caribbean, particularly Jamaica and Barbados. That's where I'm from. So this model of the psychological roots of vaccine hesitancy. So my model is based on the theory on cognitive psychology, which is the study of mental processes such as information processing, intelligence, memory, decision making, problem solving, and the cognitive model of emotional disorders, which is the foundation for cognitive behavioral therapy. And this cognitive model of emotional disorders in CBT suggests that how you think about a situation, not the situation per se, but how you think about the situation influences how you feel and behave. And I found it interesting that Dr. Buckland, I was wondering if she's read my slides before I started, spoke just now about we filter information. And that's exactly what we do. And we all have different filters. So how we interpret information, the same information, will change from person to person, and then the emotional and the behavioral responses would reflect that filter. So this little model I have here is a combination of the cognitive psychology and the CBT conceptualization of emotion and behavior. So we will start normally with, when we're creating a model, the overarching experiences, the culture, social environment that the person is experiencing right now. And we have our overarching situation, obviously, for the past 2 years is the pandemic. Then we look at triggers in the CBT model, any stimulus that elicit a response in us. And then we go to the automatic thoughts. The automatic thoughts are the interpretation of our experience of that stimulus or stimuli. For the purposes of this model for vaccine hesitancy, I have a couple of things that may know that always influence our automatic thoughts, our interpretation of the information that interpretation of our perceptions. And the purpose of this presentation is our heuristics, disinformation, and misinformation. And where the remainder of this presentation will look at heuristics, how they're influencing how you think and experience the information about how you think about that question, will I take the vaccine? And how things like disinformation and misinformation will influence the heuristics. And then we have finally, once you have those automatic thoughts and you are using that filter on your perceptions, the emotions and the behaviors that are as a response to that filter. All right. Oh boy. Just want to move this. Where can I move this? Okay. Okay, right here. All right. So now I've elaborated that model a little more, and we're coming to what we call like a case conceptualization. So I have Jane and John Doe in my office, and they're talking about their vaccine hesitancy. So I want to create a conceptualization of their behaviors and their hesitancy. So this is what I would typically do. Again, we start with we can look at the broader life experiences that have been taking place in the past 2 years. We have the pandemic, of course. We have the pandemic that has given rise to mortality, morbidity, illness, and the mitigation factors. The mitigation factors like mask wearing, isolation, social distancing, and for the purpose of this presentation, lockdowns, and for the purpose of this presentation, vaccines as a mitigation measure. But in all of this, the prevailing fear and uncertainty about, I have here health outcomes of self and others, but about everything, about your health, of course, which is of utmost important because that can talk about the morbidity and the mortality. Then there's financial, then there's your children. Dr. Shetty looked at that very well. how we worry about our children for the health wise, the education, their adjustment during this pandemic. We're worried about everything, uncertainty about everything, financial uncertainty, work, everything. So that uncertainty, so that's really one of the broader life experience now, a pervasive uncertainty. Then you have the trigger. So a part of the mitigation that we have been thankful for most of us is the advent of the vaccines. At some point in time for the past 6 months to a year, you have been posed the question, are you taking the vaccine? And in my conceptualization, I use that as a trigger. It might be coming from a conversation, an ad at work, a requirement at work, among your friends to be included in a social group, to go back to school. Just a conversation, are you taking a vaccine? It might be a demand, it might be a query, but that is the stimulus that we are forced with right now. So it leads you to think, well, am I taking a vaccine? Here is where the psychology, the root, one of the root causes for the vaccine hesitation. Now, in the other model, I showed you the automatic thoughts, but the automatic thoughts and images that come to mind, those filters that come to mind when you try to make a decision in this time of uncertainty are the heuristics. And the heuristics, which I'm going to really elaborate on in the next slide, are those images or thoughts that immediately come to mind. And normally any information that immediately comes to mind about the vaccine, about the advantages and disadvantages of taking this vaccine, and all the very sensational and sometimes sensational advantages of taking the vaccine. But since we're talking about vaccine hesitancy here, we're going to focus on the disadvantages that might immediately come to mind, like vaccine causing infertility, blood clots. The vaccine was developed too quickly. And often this information is delivered to you immediately on your phone, via WhatsApp, via a voice note, social media. You don't have to look very far for it's there, it's everywhere. In the paper, letters to the editor. I printed one the other day, anywhere, YouTube, anywhere. And we're going to speak about why that's so important and the meaning. So once we have these automatic thoughts or these automatic memories or these automatic experiences or images, anything that immediately comes to mind that is triggered, that is in response to that trigger question, you then have to interpret what these images mean to you. So the meaning of these automatic thoughts, and here for my case conceptualizations, we could imagine that the person might say, vaccines seem to be dangerous for everyone. Vaccines seem to be dangerous, including young people. COVID is only dangerous for old people. COVID isn't as bad for me as the vaccine. And then you have your emotional and behavioral response: fear, anxiety, worry, defiance, anger, possibly, and behaviors such as avoidance, activism, paralysis, and obviously vaccine hesitancy. Oops. Why? So what is a heuristic? And this is very central to my little model here. A heuristic process is a problem-solving method, which is, although it's imprecise, is sufficient to solve a problem immediately. So for example, if you have a heuristic for measurement, let's say you wanted to measure the square footage of a room, but you don't have a tape measure, you can walk heel to toe and count the number of feet in the breadth and the width of the room, the width and the length of the room. And that would give you an idea, although imprecise, but it is a problem solving method that would give you a rough, dirty idea of how big this room is until you get your tape measure. All right. Heuristics are also used in social cognition. These are decision-making tools that people use to make inferences and draw conclusions simply, easily, and for the most part, accurately. So we use heuristics every single day in almost every decision we have to make. We cannot walk around with a dictionary and do an experiment every time we need to make a decision, or do some probability statistics every time we need to make a decision. So we have to use heuristics. And cognitive heuristics are important because they allow us to make countless decisions without a cognitive overload. We need to make our decisions fast. We need to make them relatively accurately and efficiently. And then when we learn from experience from the previous decision making, the next time we have to make that decision, we might make it even faster and even more accurately. That's why old people are wiser than young people, for the most part. So heuristics is a decision, is a process of problem solving. But there are different types of ways we try to solve problems. And we're going to be talking today about what we call the availability heuristic. What comes to mind first? So these two gentlemen called Amos Tversky and Daniel Kahneman in 1974 published a paper entitled Judgments Under Uncertainty, Heuristics and Biases. And their basic, well, not basic, their idea for this paper is, how do people without any precise measurement make a decision or come to understand the frequency or the dimensions or the frequency of a category or a quantity? And they came up with this idea that they test and was verified, that we decide on the frequency of something, on the importance of something, basically how quickly we can bring it to mind, how quickly we can retrieve this information. I'll give you an example. I caught myself in the availability heuristic just the other day. So I was talking to someone about the pandemic and everything. And I said, you know, so many relationships breaking up during COVID pandemic. And I went on, and what quickly came to mind is the 3 people I knew that recently had a breakup in their relationship. So for me, there's a lot of divorces during the pandemic. So when I was further elaborating on that, I said, but wait, I know these people were going through problems long before the pandemic, you know. So I'm not so sure it's the pandemic that caused it, but when I think about the relationship between people and the pandemic, I think about these 3 people that I know are no longer together. So therefore, there's a lot of divorces during the pandemic. The availability heuristic is defined as the process of estimating the frequency of a category by the ease with which instances come to mind. The easier it is to bring an instance of some group or category to mind, the more prevalent and prominent these are judged to be. It is the ease of the recall, but not the amount of information recalled. So it doesn't matter if you can recall 10 million people. If you needed days and weeks and struggled to recall that information, it is not seen as prevalent or as important than if you could recall only 2 or three items in that category immediately. So let me just go over that again. It is defined as the process of estimating the frequency of a category by the ease with which instances come to mind. And for the purposes of our model, when you're asked by someone, are you going to take the vaccine? What immediately comes to mind for you? Do you immediately think about that WhatsApp message you got showing someone crying about being harmed by a vaccine, not even this vaccine, maybe some other vaccine, or story about somebody getting worrying about infertility and how the substances in the vaccine by some expert may cause some either harm, or there's another message that immediately comes to mind that you don't know what's in the vaccine. They developed it so fast, unlike other vaccines, you just don't know. Again, really pushing that uncertainty. In general, heuristics are useful, but they sometimes lead to severe and systematic errors. Just like my whole heuristic about relationships and COVID, because I immediately thought of 3 people and I said, yeah, man, it's prevalent. And then I said, like, probably would not be together if there was no COVID. And these are some examples that might, like I said, of information that might quickly come to mind, or might be delivered to our social media inbox, whether we want them or not. But we have it right there in hand. So this little graphic shows all the information that's available to make a decision, but really the information we use to make a decision. It must be recent, it's frequent, it's often extreme, vivid, and negative. That's what's available to us for very good reasons. We will remember things that we're exposed to recently and frequently and extreme in a vivid way and particularly negative. We attend to all of these categories. If anything falls in this category, we will attend to it, and it will be in our inbox, our mental inbox, very, very quickly. So every heuristic has a bias. Everything, because it's a quick, dirty, imprecise measure of problem solving and decision making. You don't necessarily always need it to be accurate. You just need it to be there and about. But bias is inherent. Error is inherent. So you have to be careful about making some really big, important decisions based solely on heuristics. Biases are the severe and systematic errors that occur when using heuristics. Like if I use my heel and toe to measure the room, I would be careful to make some really important decisions just based on that rough measure. I need to come back with my tape measure and then do a proper measurement before I make any decisions. Severe and systematic errors occur when using heuristics. There are several in cognitive psychology. There are several biases that impact this particular heuristic, the availability heuristic, and there are many other heuristics, by the way, that we haven't discussed here, but this particular heuristic, we're going to focus on the biases and the errors that may impact the availability heuristic. So the first one is the familiarity bias. Errors can occur when one category is more familiar than another. If there's something, if you were trying to compare, somebody gave you a category of tonsil stones versus relationships, you're going to be way more familiar with the relationship category than the tonsil stone category. And probably, yes, please.
Excuse me, we have a short time left in your presentation. Just letting
Yeah.
you know.
All right,
Thank
we're going to be over in like 2 slides. So information that is less well known will be more likely to be difficult to retrieve, but that doesn't mean it occurs less frequently. And then there's the illusion of correlation. This is a bias in the judgment of frequency between two events. You know, like a social media post that look at vaccinated persons. I was just looking on, just going through these posts, and then vaccinated persons and sudden death. They seem to just, there's a lot of posts that put these two events very, very closely together, although there's no evidence that they're related. And then the salience bias. This is anything that comes to you that is very dramatic, very emotionally laden, very potent, and seems very prominent and important. So voice notes, videos of potential or actual harm of vaccines on whatever social media you're using. And this is, so the vaccine, these social media messages on vaccines can come in a very dramatic and effective way, and very negative and scary. But when we get information on the COVID and the treatment of COVID and the ill effects of COVID, you know, it can be very, you know, in the paper, very black and white, and not necessarily available for immediate recall. And it also might fall outside the category of that 25 to 39-year-olds who are worrying about how the vaccine will affect them versus being sick from COVID. And another influence on that automatic thoughts, and of course the heuristics. The available heuristic is only as good as the information available. And there's a lot of misinformation, information that is false but not created with the intention to cause harm. And then disinformation or fake news, information that is false and deliberately created to cause harm. And it will travel faster and further than the truth. So these categories of information go into the available heuristics, which will influence our automatic thoughts and how we feel and behave. And then I just made a quick note on the other psychological reasons for vaccine hesitancy. There are other types of biases, like the confirmation bias, which is we're only going to attend for information that is in keeping with our belief system, and we're going to ignore information outside of that system. Confidence bias, overconfidence in our characteristics and our abilities. I remember reading an article in Barbados paper about this person who is promoting vaccine hesitancy against the mandate, and she was confident that her immune system can fight the COVID infection. She's confident, she just knows it can. Or maybe it can, but there's a lot of people who felt that way too. And then needle phobias. Research has shown that up to 25% of adults, phobias and fears outside of any of the heuristics can cause vaccine hesitancy. There's research that shows up to 25% of adults have fear of needles. And that's it. Thank you.
Thank you very much, Dr. Thank you very much, Dr. Prescott. Very enlightening about heuristics. So, with the pun on words, we have the misinformation, which is mistaken information, and disinformation, which is deceiving information. If you get the deceiving for disinformation.
Disinformation versus misinformation.
So we have DIS, you can say deceive, set to deceive, and misinformation is really mistaken.
Yeah.
They are sincerely wrong. They really believe whatever, but they're sincerely wrong. Quite a very interesting outlook on the roots of vaccine hesitancy and resistance. At this time, I turn over to my colleague, Dr. Peter Swape, for the question and answers. Thank you so much.
Welcome.
Thank you, Aldith. I'm about to share the screen with the question and answers. Okay, here we go. First question. Let us do it this way. Okay, first question. Does this model of cognitive conceptualization also apply to vaccine acceptance?
I think so, because I was thinking about it while I was writing up the research. I was applying it to myself. Because what are my heuristics that I use to take the vaccine? And the answer I got to myself, when I think about my memories, the images that immediately come to mind for me for accepting the vaccine, I had an image of myself standing up as a child, taking my polio drop and sugar cube. I thought of everybody I knew who took the vaccine and never had any harm given to them. Vaccines have been good to me. Those are my heuristics. That's the information I immediately draw on when I think about the vaccine.
Okay. Second, comment on the role of celebrity marketing to influence public opinion in relation to vaccine hesitancy.
Celebrity marketing too. Again, celebrities are more prominent. They're more dramatic. The information is way more available to us. So we tend to look towards, so they're more in the public sphere. So if you're gonna think about someone, you're not gonna think Jane Doe said something, but maybe some celebrity that is important to you. You're going to recall their opinion much faster than you recall something you saw in the paper or some comment somebody said offhand.
I guess that's the same thing with marketing.
It's the same thing with marketing. Yeah, it's the same thing with marketing.
Okay, and then how would you relate heuristic bias to QAnon? Can you use it here too?
Versus a sedate leader, I don't know. I know QAnon is, but I don't know enough about them to look at the relationship between heuristic bias and QAnon. So I gotta pass this one. And I'm not sure what the thing for sedate leader is.
Okay, thank you very much. That was a very interesting and very clear presentation. It certainly opened my eyes a lot to how we make decisions and why we have vaccine hesitancy. We're gonna cut our question and answer short here because we're trying to make up some time. So we're gonna go ahead and Aldith, I'm gonna turn this over to you.
All right.
Thank you, Peter, and thank you very much, Dr. Prescott. Excellent presentation. At this time, we invite MedImpex Jamaica to bring the responses presentation.
A pleasant day, everyone. My name is Christopher Fuller, medical representative with MedImpex, and it is certainly a pleasure for MedImpex to be a part of any effort supporting our medical doctors. Today, I'll be touching on 2 of our products.
It is a pleasure for me to be part of this virtual conference this afternoon.
Just a quick reminder of our change of address.
Our presentation will be in the form of a will be highlighted. So the sound video.
We are at 21 Balmoral Avenue, Kingston 10, and our numbers are listed below, right? So we are indeed open for business. Let's get straight to the meat of the matter. Stimulotan. That is our sertraline, a 50 milligram preparation, and it is a selective serotonin reuptake inhibitor. In the midst of this global pandemic, each of us is forced to become a part of the mechanism to ensure our own safety and that of our relatives. We have been affected in many ways. Some of us have had our salaries reduced. Some have lost their jobs, and as a result, they may feel isolated, stressed, and hopeless. And this may become a prelude to things like anxiety and depression. Stimulation is indicated to treat depression, panic attacks, obsessive compulsive disorders. So it's right in line to assist in those patients who may be affected in this pandemic. With regard to its efficacy, it is indeed a potent SSRI. So you're guaranteed results in terms of its safety and side effect profile. Stimulation is well tolerated, and onset of action is within 4.5 to about 8.5 hours after dosing. The mechanism of action, it does act within the brain. It increases serotonin, and increases in serotonin at the synaptic gap really helps in contributing to happiness and a feeling of well-being. And that is what stimulation is geared toward producing, in helping persons to lift their depression or anxiety. The dosage for depression and OCD, we're looking at 50 milligrams once per day, best taken with food, and the complete therapeutic effect would be roughly about 2 to 4 weeks, or attained within 2 to 4 weeks. On the panic disorder side, or anxiety, it is recommended that we titrate up. For the first week, it's 25 milligrams once daily, again with food. And then for the second week, we move up to 50 milligrams once daily, again with food. And therapeutic effect will maximum daily dose is 200 milligrams. For premature ejaculation, which really is an off-label indication, but it has been used quite widely in that regard, 50 milligrams once a day, 6 weeks, and then when needed thereafter. There is a prophylaxis regime of 50 milligrams PRN 2 hours prior to sexual intercourse. Right? Efficacy in treating premature ejaculation is 60%, roughly. Dosage adjustments for special populations, certainly the elderly, there is no dosing reduction necessary. Renal impairment, no modification necessary. Hepatic impairment, a lower dose, or the usual dose with longer dosage intervals. In terms of pregnancy and nursing, safety has not been established and it can be excreted in breast milk, so caution may be necessary in those patients. This graph shows the significant decrease that can be attained in panic attack in treating a patient with stimulation as opposed to placebo. And as we can see, the reduction, as highlighted by the brown area, is indeed significant. So you can expect excellent results with your patients on stimulation. Benefits. Sertraline is among the most potent SSRIs, as was mentioned earlier. Age has no influence on sertraline clearance. Plasma levels and clearance can be quickly and effectively controlled. Smaller effect on the cytochrome P450 system, and thus that reduces drug-to-drug interactions. Now, here are some of the competitors. We have PMS sertraline, and of course the brand Zoloft, of course Stimulation there at the top. Price per tablet, Stimulation comes in at $95. PMS is less, while Zoloft is significantly more. So Stimulation comes in roughly in the middle of the options that are available. This is what the package looks like. And Similotan again is a good option. Retails for at approximately $135 per tab. There's the NHF subsidy, which would have brought it down to the figure shown on the previous graph, roughly about $90 to $95. So you can expect your patients to regain their confidence and be happy on Similotan. Now, quickly I'll go through Palixid or donepezil, geared toward treating Alzheimer's. How does it work? The mechanism of action. Donepezil is a cholinesterase inhibitor. It is a specific and reversible inhibitor of acetylcholine, which is a predominant cholinesterase in the brain. And it is postulated to exert its therapeutic effect by enhancing cholinergic function through increased concentrations of acetylcholine. There is no evidence that donepezil alters the course of the underlying dementing process. So it may slow but not stop the progression of the condition. So it is geared towards treating mild to moderate or moderately severe Alzheimer's disease. This chart refers to the mechanism of action, and there we see choline acetyltransferase converting choline to acetylcholine, and then the acetylcholinesterase converts that acetylcholine to acetate and choline. Now this choline esterase cleaves the acetylcholine to acetate and choline to end its action, and it's located in both pre and post synapses. The cholinesterase inhibitors inactivate the acetylcholinesterase by reversibly binding to the enzyme, and cholinesterase inhibitors indirectly provide a cholinergic action by prolonging the lifetime of acetylcholine. Clearance is due to both hepatic metabolism and renal excretion at 25 to 50% and 50 to 75% respectively. The product profile: peak plasma levels within 3 to 4 hours. The half-life is 70 hours. A steady state is achieved within 3 weeks of initial therapy. Bioavailability is at 100%. Protein binding 95%. Food does not affect its absorption, so it can be taken with or without food. Metabolism is done via the liver, cytochrome P450 system, and multiple metabolites are produced, but only 2 show any activity. And then the remainder is excreted in the urine. It is indeed well tolerated, with little side effects. Improves cognition and functioning in a number of patients. 38% reduction in functional decline. So as I mentioned, slows the progression. Improves behavioral symptoms. Some of the adverse events that may be noted: bradycardia, there may be some GI upset, muscle cramps, and fatigue. Looking at the dosing, initial dosing is 5 milligrams once per day in the evening before retiring for at least 1 month. After that 1 month and a follow-up assessment, the dose can then be increased to 10 milligrams. The maximum daily dose is 10 milligrams. In cases of renal and hepatic impairment, same dosing as clearance of the drug is not affected. So 10 milligrams is sufficient for those patients with these impairments. It is not recommended in children. Here are some contraindications. The contraindications are as follows: patients with hypersensitivity to donepezil, any piperidine derivatives such as haloperidol, of course, pregnancy and lactation, it's a no-no. Drug interactions. Ketoconazole, quinidine, these are inhibitors of the 3A4. Also itraconazole, which is a inhibitor of the 2D6, and fluoxetine. All these will cause the metabolism of donepezil to be inhibited, and so caution should be taken. There are inducers which will cause the levels of donepezil to drop. Some of these are rifampicin, phenytoin, carbamazepine, and alcohol as well. So caution also needed there, right? This is a presentation of Palixid. The boxes contain 2 strips of 14 tablets, so a total of 28. The tablets are round, white, biconcave, and film coated. Comes in 5 and 10 milligram preparations. Table showing the competitors that are currently available on the market. There may be a few more, but some are not consistently available. So there's Palixid, Aricept, which is the brand, and Yasna. We do appreciate you using these products to benefit your patients, especially in this time when depression and anxiety may be on the increase, even among those with Alzheimer's, and also their caregivers too may experience this, especially in these times. Thank you very much for listening. Medimpex is always here to support you. Have a wonderful rest of the day.
Thank you. Thank you, everyone. So we've completed session 1. We have had 2 wonderful speakers, Dr. Shetty and Dr. Prescott, and wonderful sponsors presentations from Upjohn Abbott and from Medimpex. So I'm going to turn over to Dr. Ray McNotice as he's the moderator for session 2.
Thank you, Dr. Buckland. A pleasant good afternoon to you. I will be very brief in the interest of time, but let me rush to say a hearty congratulations to the Association of General Practitioners of Jamaica for their tremendous and tireless work that they have been doing. Most of these are medical practitioners, and I just don't know where the time comes from for them to be so active and so effective in the management of this association. Our speakers continue to be knowledgeable. They have gone beyond bounds in their presentation. Excellent presentation thus far, and over the year, over the months, Dr. Gordon, his executive, has been very successful in getting our own local presenters in addition to expert internationally. We also want to give thanks to the many nurses. They are the hardworking persons behind the scene, nearest to the hospital settings, and also medical students who may have been a part of this webinar. The AGP also would like to thank the arm bearers, the sponsors who continue to be excellent personnel and supporters of the association. At this time, I would like to have one of our able sponsors from Torrent Pharma, Indus Life Science, to be presented by, I see, Paul Russell, and I guess it's the same Paul Russell from the old Meadowbrook where we attend. Brother Russell, could you go ahead with your presentation?
So this is not for Paul just yet. We're going to hand over to R.A. Williams, who is here to do the presentation for Torrent Pharma. And then after that, we'll ask Mr. Dyer from Indus. Please go ahead. R.A. Williams, you're up first.
Thank you for the update.
Thank you so much. Good afternoon, everyone. I am Kiana from RA Williams. Would like to welcome you all to the webinar, and we will get right into our presentation. All right. So today we will be talking about Valparin Chrono from Torrent Pharma. But before we do that, we just want to, break the ice a bit. So we have this question on the screen, and the first person to raise their hand will receive a beautiful package from Ari Williams.
Can I play?
Anybody can play. So the first person to raise their hand is the administrator. So go right ahead, Mr. Administrator.
Hold on a second. All right, let's let the others play. So we have Audrey Brown. Audrey, you should be able to talk now. Can you speak? Unmute. Going once. Going twice. Over to Javita. Javita, your turn. Go ahead, unmute. Javita Iwudke, unmute. Nobody wants to talk to us? All right, Cora Baker, over to you. Go ahead. Okay, no, Javita, you're there. Go ahead. What's the answer? Javita, we can hear you. Go ahead. What's the answer?
Do you want to do it? Making sure to
All right, not working out. So the first person in the chat to give the answer was Shane Carter.
Okay, so congratulations, Shane Carter. Please message me privately with your contact information for you to receive your prize. All right, moving right along. So the answer is there, shorter. All right, so Valparin Chrono is a prolonged release formulation of sodium valproate and valporic acid. With this combination, it allows for even distribution in the plasma throughout the day. So we don't have the dose overload on our patients, as well as for persons who don't take medication consistently, they have less to take. So they can take once or twice daily, covering the full dose of the medication required for the age as well as the body mass. So as I previously said, it is a controlled release tablet, releasing the valporic acid immediately, then it proceeds to release the sodium valproate after it is broken down. Now, Valparin Chrono is an anticonvulsant and anti-epileptic drug, and it is suitable for the use of other things. So, for example, it can be used for schizophrenia, bipolar disorder, a mood stabilizer, sometimes in anxiety, as well as to treat migraines. And Valparin Chrono comes in two strengths. It is in 300 milligrams and 500 milligrams. So the active ingredient in the 300 milligram is 200 milligrams of sodium valproate and 87 milligrams of valporic acid. And this is priced conveniently at $3,500. while the 500 milligram has 333 milligrams of sodium valproate and 145 milligrams of valproic acid, conveniently priced at 7,000. Now, we have some comparative studies for our sodium valproate, and as you can see, it was compared to another epileptic drug to treat status epilepticus. And in this study, they had 68 patients with status epilepticus. And with these 82 patients, 14 were excluded. So the results will be given for 68 patients. So the seizures were aborted for 66% in the valproic acid group and 42% in the other group. As a second choice for refractory patients, valproic acid was effective in 79%, while the other was 25%. So it is obviously superior in this study. So we conclude that the sodium valproate is definitely more efficacious with convulsive status epilepticus with fewer side effects. And in another study, which other persons might be familiar with this drug, it is Keppra. So the sodium valproate was used to treat juvenile epilepsy, the myoclonic epilepsies. As you can see, the structure of the study, it was divided 34 for sodium valproate and 32 for the Keppra. And it was concluded that sodium valproate is slightly more efficacious than the levetiracetam in this study. Now, while it is slightly more efficacious, it is important to know that because it has the controlled release formulation, more tolerance would be there in patient compliance because they have less doses to take. And as I had mentioned, the other uses of valproate chrono, the drug can be used for delirium, schizophrenia, as I mentioned, bipolar disorder, migraines, and anxiety disorder. And I have another giveaway. So on your screen is the first question. What are the two strengths of the valproate chrono? And the first person to respond will receive a package.
All right, so guys, first person to type in the chat gets the package.
And we have the answer from Lacian Barnett, Jeffrey. So
Okay.
Please message me privately for your prize.
Congrats, Lacian. So the correct answer is 300 and 500 milligrams?
Yes, it is. And our, ooh, let's hope nobody saw that. And our second question is displayed on the screen. First person to answer receives a prize.
Shawanique Barrett says true.
Right. So congratulations, Miss Barrett. So as I had said when I began the presentation, my name is Kayana Jenkins. I'm medical representative from RE Williams, and you can contact me at the numbers provided or by email. So I do hope the presentation was informative to you, or you have learned something today that you did not know. All right, thank you so much.
Thank you so very much. And now we go to our next sponsor, as introduced before, which is Indus Life Sciences. Mr. Daya, are you there? You can go ahead and share your screen.
Thanks, Mr. Sam. I'm just sharing my screen.
Go ahead. Yep, we're seeing your screen.
Yes. Good afternoon, everyone. On behalf of Indus Life Science, I thank the presenters, moderators, as well as participants for this virtual conference. And Indus Life Sciences, which stands for Indus, which basically means I and us. I and us serve the community. That's how it is. Indus. We are based in 30 Carrift Avenue, as well as we are also with R.A. Williams. So just to refer, some of the brands is very popular across the Caribbean. One of our vaginal insert. I'm pretty sure all prescribers is aware of Dresby, and they must be recommending it to the patients, which is ideal for bacterial vaginosis, trichomoral vaginitis, candidiasis, as well as mixed infection. And the gel formulation offers quite a lot of benefit, as because the compliance is good. It's not for 7 days or 10 days, it's only for 5 nights. And Dresby is the first gel that has been introduced in Caribbean with 5 applicators, makes it hygiene. And the brand is very popular in many countries across the globe. It's currently more than 38 countries the brand is available, especially here in Caribbean. We are in Jamaica, as well as we are in Cayman, Bahamas, and soon we are going to launch it in Guyana, Barbados before end of this year. So, and we have another interesting product that's for allergy. As you know, we are getting a lot of rain and we are heading towards December. The weather will change. So if the patient has any symptoms for allergy, it could be rhinorrhea, running nose, urticaria, angioedema. We have the 2nd generation antihistamine, which is our fexofenadine. When I say 2nd generation, obviously it has a lot of benefits, as least sedation, I could say absence of sedation, and devoid of anticholinergic effects, especially dryness of mouth, constipation, and other blurred vision, and also. And our brand name is Fexil. How we coined it? Fix it, fix the allergy, fix it with Fexil. That's our brand name. We have 120 and 180 milligram. The 120 is over the counter and 180 milligram is prescription. And it's very affordable. I'm not bashing, the brand is also good, but when you compare the cost, Fexil is the most affordable among any fexofenadine. Each pill of 120 milligram is around $40 per tablet, which is, you all know, it is once a day. It works 24 hours around the clock. And 180 milligram cost around $60, whereas the brand is almost 5 times expensive than this. I mean, this is cost per pill. And we have a nice drug for pain management, basically for topical. That's our Capsitop, as the brand itself conveys the message. How we coined it: capsaicin topical rub, capsaicin topical gel. That is Capsitop. Is good for all pain. Is knee pain, joint pain, wrist pain, neck pain, back pain, shoulder pain, frozen shoulders, arthritis pain, and has 3 active ingredients. And then one is the capsaicin, which is basically the pepper that we take, capsicum, is extract of it, approved by US FDA for neuropathic pain. And capsaicin depletes pain by inhibiting substance P. And it has also has diclofenac, which we all know depletes pain by inhibiting prostaglandin. And also methyl salicylate is the 3rd ingredient, which also depletes pain by counter pain mechanism. And the liver menthol, what we see, is basically a cooling agent. It also relaxes the muscles and tissues, thereby helps these 3 active drugs to penetrate deep into tissues and muscles. And Capsitop is over the counter. There's no need for prescription. It's a 30-gram tube, and it's around $750 to $800 in the pharmacy. And one caution is that a gentle spread is sufficient, need not to rub aggressively, as some may complain of burning sensation because as one of the ingredient is capsaicin, which is extract of pepper. Some may like it, they say it's working. So however, as a caution, a gentle spread is sufficient with Capsitop. Obviously, they have to wash the hands thoroughly. And the neuropathic pain management, we just saw other Capsitop, and this is that was a rub, and this is a pill to be consumed, and that's our neurobalin, pregabalin for dampening neuropathic pain, post-therapeutic neuralgia, fibromyalgia, sciatica, radiculopathy, many indications. It is recommended. And how we coined the brand name is neuropathic pain, pregabalin, neurobalin. That's how we coined it. Neurobalin is nothing but neuropathic pain, pregabalin. We have both the strengths 75 and 150. The most starting dose is 75, and then you can step up to 150. And I've seen prescription 150 twice a day also. The maximum dose is recommended 600 is the maximum dose. And if it is 150 milligram, better to be at bedtime. So to beat the side effects like drowsiness or hallucination. The most important point of this brand is that we are the first company which broke the barrier of pricing. Before we launched it, the cost, I'm not bashing the brand is excellent, but if you could see the price, it's way expensive. Each pack of 75 milligram is close to $10,000, and you could see our neurobalin just cost $2,850 for 30 pills, and 150 is to $3,250. Very interestingly, both the strength of subsidies come by NHF. Especially the 150 milligram, 100% is subsidized with the patient has NHF card. Under epilepsy as well as diabetic neuropathic pain, it is gets subsidized. And 75 milligram, literally 85% of the cost is subsidized. And I have a proof for that. If you could see the next slide, I'm pretty sure all will agree with me. You could see on the right-hand side of your screen where this is actually a copy of a receipt that was just filled in this year, not long ago in the month of April. The patient has bought in 30 pills of neurobalin 75. The actual price for a month supply is $2,861.50. The NHF subsidy is $2,615.70. So the patient hardly paid less than $300 for a month supply. So that's why I always keep saying it is not physical pain. Sometimes the cost of the drug causes monetary pain. And neurobalin is the first brand of pregabalin has ensured both physical as well as monetary pain is get eliminated. So neurobalin, we have the coupons which our MedRep will pass and drop it to you. When you give this coupon, the patient, apart from this price benefit, they'll also get free pills for every 30 pills they buy. And the last product, which basically is our supplement, I cannot close any presentation without mentioning about amino pep. We call as a big juice because this is the first formula of Caribbean which offers the most comprehensive supplement, which offers protein, especially the 10 amino acids. Also, when I say 10 amino acids, these are the 10 amino acids starting from histidine, arginine, tryptophan. Very difficult to remember all 10. So I have a nice acronym, HATV till 10 p.m. You just remember HATV till 10 p.m. All 10 essential amino acids are there. And especially at this pandemic time, we know we all stressed out, as the topic itself is on that. Today presentations are on stress, how to cope up with that, and supplements or some of them could really help to as a stress buster, as being, tryptophan is one of the amino acids as found to be really useful to reduce the stress. Of course, we have other amino acids like lysine, good for kids to promote growth, as well as arginine, good for healing, phenylalanine, good for concentration, memory, like that, and especially tryptophan is found to be good as a stress buster also. And growing phase, obviously kids are under more stress, whether it's online class or in sports. So they also need sometimes a supplement that can help them to perform both academically as well as in sports. So we have amino pep, that's our supplement. And convalescence, somebody's in quarantine or they're recovering from any other conditions from hospital stay or so. So if they are supplemented with the right supplement like amino pep, it can help them mentally as well as physically to recover faster. And the composition of amino pep is quite big, as you could see in the screen. It has 10 essential amino acids which can helps to complete a protein formation, plus all vitamins are there, right from vitamin A, D3, vitamin C, B1, B2, B6, B12. It has a little bit of folic acid, it has calcium, it has zinc, which is 50 milligram is there, which is ideal for to boost the immunity, especially this pandemic. A lot of discussion goes on immunity. So if you have 50 milligram of zinc per day, it's a therapeutic dose. I even normally just even do mention it. Those who have 2 doses of vaccine, if you want to avoid booster dose, please take zinc. Probably aminopep could be a substitute for that also. 5 meals twice a day can boost your immunity. And the dose is normally 10 mils in once or divided dose for adults, and kids is 5 mils once or divided dose, or maximum go to 2 times a day. And especially those who are in quarantine, or those are chemotherapy treatment, or especially those who are also underwent surgery, or the C13 patients, immunocompromised people, you can nothing wrong, you can step up the dose up to 15 mils per day. And it's a chocolate caramel flavor. There's no natural sugar on it, so it can be safely given for diabetic patients also, and any other persons. The age normally is recommended is 2 years and above. Less than 2 years, mother's milk is the best. So anybody about 2 years can take aminopep, as a brand name always conveys the message, gives a pep to your step, especially at this pandemic time, over stressed. Please give a pep to your step with aminopep. And also like to share my contact number. If somebody is interested in samples, you can just WhatsApp to this number, and we'll ensure that we'll organize to deliver samples to you, or you can collect it from our office. Thank you very much, Mr. Sam. Thank you all. Stay safe.
Thank you, our midreps. They're always well educated on your products, and also we enjoy the heart of marketing and competition. Excellent presentations. Probably hope I'm just to present our other speakers. The first of who will be Dr. Tosan Livingstone. And I see beside her name, Nana Obi. I really admire that little put. I don't know if that's a married name or that's a pet name, but Nana Obi. She, in fact, gained her MBBS some years ago and is a developmental behavioral specialist in Morrison, New Jersey. She presently practices at Child Development Center, and of course, she is a board certified in development and behavioral science. Now, she's going to present to us on early screening and intervention in autism spectrum disorder and ADHD. We all have an idea that autism spectrum disorder, ADHD, is usually a long life-term condition and characterized by social and other communication deficits. But the challenge is managing when diagnosis has been made, especially where the parents are concerned. I'm no expert at this. We have Nana Obi, Dr. Tosan, to present to us on the topic which we anxiously awaited. Help me welcome Dr. Tosan Livingstone. Floor is your, Doc.
Thank you. Hello, everybody. Good afternoon. I'm going to start my presentation, and I'm going to start my presentation with autism spectrum disorders, and then I will go on to ADHD. So I am going to focus on early screening. I'm going to focus on early screening and intervention, and then also resources available in Jamaica. And this is me. My name is Dr. Tosan Livingstone. I'm a neurodevelopmental pediatrician, and I am now practicing neurodevelopmental pediatrics in Jamaica. I'm going to start off by first defining what autism spectrum disorder is, then the prevalence, which is how common it is, the etiology, what causes it, the symptoms, how do the children present, and then I'll go on to the early screening, intervention, and resources available in Jamaica. So the definition, and this is very important as we're going to be coming back to this definition several times during this presentation. So it is a neurodevelopmental disorder that is characterized by difficulty with social communication and social interaction, as well as restricted repetitive patterns of behavior, interests, or activities. And the prevalence, the global prevalence of autism spectrum disorders is about 1 in 132. This prevalence has been increasing all over the world over the years. And in Jamaica, it is currently about 1 in 68. And the latest studies of this in Jamaica was in 2014. The reason for this apparent increase in prevalence worldwide may be related to improved awareness, expansion of the diagnostic criteria, better diagnostic tools, and improved reporting. It is about 4 times more common in boys than in girls. And in my practice over the years, I find that about 75%, at least 75% of my patients, and when I diagnose autism spectrum, they're boys. And since the majority of those affected are male, there is some concern about the interaction between testosterone and brain development. Autism spectrum disorder occurs in all racial, ethnic, and socio-economic groups. I've seen children from all different parts of the world with this condition. So no single cause has been determined as to the etiology, but researchers believe that it is partly genetic and partly environmental. And the reason why they believe it's partly genetic is because studies have shown that among identical twins, if one twin has autism spectrum disorder, then the other twin is likely to be affected with autism spectrum disorder more than 30% of the time. And then also parents who have one child with autism spectrum disorder have a 2 to 18% chance of having a second child who is also affected. The incidence of autism spectrum disorder in the general public is about 1%. So continuing with the etiology, we find that children born to older parents are at a higher risk of having autism spectrum disorder. It also tends to occur more often in children with genetic disorders. So in addition to the genetic disorders, they can also have autism spectrum disorder. The level of intellectual functioning in children with autism spectrum disorder is variable. Almost half of them, which is 44% of the children with autism spectrum disorder, have average or above average intelligence. The rest of them have below average intelligence or intellectual disability. Autism spectrum disorder, as it is appropriately called, is a spectrum. So you have different types of presentation and you do not find 2 children that present exactly the same. In my practice, I've had twins with autism spectrum disorder, and each twin's autism spectrum disorder is different from the other twin. So how does it present? This slide is very, very important. This is, I believe, is the most important slide that I'm going to show you guys, because you can start to pick up signs of autism spectrum disorder as early as 12 to 18 months. So the screening tools that we has been developed actually start early, you know. So at 12 to 18 months in children, these are the different areas that you can see the differences in their behavior and their development. The first one is visual behavior. In these children, they tend to have poor eye contact. They have difficulty with eye tracking, so they do not track objects or even track people. They have prolonged inspection of objects. They have difficulty with joint attention. And what joint attention is the shared focus of two individuals on an object. So that means if the parent calls the child and says, hey, Johnny, look, Johnny is supposed to look at the parent and then look at what the parent is looking at. And that is joint attention. And in children with autism spectrum disorder, they have a big problem with joint attention. They do not look at what the parents are looking at. In the section for motor skills, they tend to have delayed fine and gross motor skills, and they tend to have atypical motor behavior. And I will show you guys a video of what atypical motor behavior looks like. This could range anywhere from toe walking, hand flapping, hand mannerisms, and body posturing. These children in their play have limited and repetitive toy play. With their social communication, they have difficulty responding to their name, which is usually one of the presenting complaints that parents have, that their child is not responding when their name is called. These children have lack of social smiling, and they can have delayed use of gestures like pointing. This is very important. Pointing starts anywhere between 12 and 18 months of age, and these children are delayed or do not even have pointing at all. Pointing is a fine motor skill that is used for early social and communication interactions. In terms of their language, children with autism spectrum disorder tend to be delayed with their language even as early as 12 to 18 months, where you can have the delayed babbling and delay in using single words to communicate. Now, this is a video of a normal 12-month-old.
Told us, Hattie. 1.
So you can see her joy, how she's paying attention to her grandmother, and she's isolating that finger already at 12 months of age. So this is what you expect to see. But this is a video of a child that I saw recently, a 23-month-old in my office with autism spectrum disorder. And this is what she was doing. You can see that she's lying on the floor. These children tend to have like low muscle tone, and they like to lie down on the ground and play on the ground. She was given a toy car, and instead of rolling the car in a regular way to play with the car, she turns the car sideways and she's playing with the wheels of the car. This is a classic presentation when you give a child with autism spectrum at this age. When you give them a toy, they tend not to play with the toy in a regular way. They play with the toy in an abnormal way. Okay, this is atypical motor behavior, and just watch.
Sometimes she rolls her eyeballs in a weird way, right? Yeah, I see that.
So these are things that you can see when the child comes to your office. If you give them objects to play with or toys to play with, you can see some of these behaviors. This is the same child. She's sitting down in the corner of the room, and they do that because they do not want social interaction with the doctor. So they go as far away from the doctor as possible. So she's sitting in the corner of the room, just trying to get away from me. And when given these toys, she picks up the spoon and look at what she's doing with the spoon. This is what you call flipping of objects. They flip objects and they can also spin objects. Now, this is the same child. Remember I said the muscle tone tends to be a little bit low and they like to be on the ground. So she's on the ground and she was actually crawling. There were times when she was crawling on the ground. And this is a 23-month-old, and sometimes she would stand and walk. And you can see her sitting in the corner of the room, just trying to get away from the doctor. So research has shown that a diagnosis of autism spectrum can be made reliably before 2 years of age. And in children who have been diagnosed before 2 years of age, provisional diagnosis at that age overwhelmingly correlates with the same diagnosis when these kids are at 4 years of age. So early detection and early intervention is very important in children, and it leads to a better prognosis. And the reason is because of the plasticity of their brain at that age when they're still very young. So it is the ability for the brain to reorganize and adapt. This is greatest in the first years of life, and it decreases with age. Early intervention should be initiated as soon as a suspicion of autism spectrum disorder is made, even before the child has been seen by a specialist for it. So this is the screening. This is very important. And this screening is called the MCHAT. Okay, it's a checklist for autism in toddlers. And it's to be done at the 18-month visit and at the 24-month visit, which is when children usually present to their physicians for a physical. And it is 20 questions, yes and no. It has been tested on children between the ages of 16 to 30 months. It's available in several languages, and it's a free download and free scoring. And I actually use it between the ages of 18 and 36 months because the children don't usually come to the doctor at 16 months, but they will come at 18 months, and they will come at 24 months, they will come at 30 months, and they will also come at 36 months. So any time from between 18 and 36 months, you can use this autism MCHAT screening form for these children. And I will show you what it looks like. Okay, this is what it looks like. You go on the internet and you download it, and you can print it out. It's a free download. So I print it out and I have several copies in my office. There are 20 yes and no questions. You give it to the parent to complete. They can complete it in less than 5 minutes. And the most important questions, these questions were generated based on the presentation, the way autism spectrum kids present between 12 and 18 months, as I had showed you earlier on. So these are questions about joint attention. These are questions about pointing. These are questions about responding to their name. And as you can see, I'll tell you how easy it is to score. The download also has scoring instructions, but I'll show you how easy it is to score. When the parents circle the appropriate response, you take the form from them and you look at number 2, the correct response is no. Number 5, the correct response is no. And number 12, the correct response is no. Everything else should be a yes, and that is a passed MCHAT. So all you have to do after the parent have circled the appropriate responses is just look at the form, go to number 2, and if it's a no, that's a pass. If it's a yes, it's a fail. You go to number 5, if it's a no, it's a pass. If it's a yes, it's a fail. And you go to number 12, if it's a no, it's a pass. If it's a yes, it's a fail. Everything else should be a yes, and that's a passed MCHAT. So I will show you what some actual MCHATs look like that I have done. Okay, this one is a past MCHAT that I did on the child recently. The parents circled the appropriate responses, and all I did was go to number 2, no, that's a check. Number 5, no, that's a check. Number 12, no, that's a check. And everything else should be a yes. This is a past MCHAT. Okay, these are two children that I saw recently. They both had failed MCHATs. This first one was a 26-month-old, and this second one was the 23-month-old that I showed you in the video earlier on. So I checked. Number 2, no, that's a check. Number 5, no, that's a check. Number 12, no, that's a check. Everything else should be a yes. But this child had 11 no's, and this child had 8 no's. So these two are failed MCHATs and should be referred immediately for further evaluation. And then you can also intervene in the meantime while the child is, while you're trying to further evaluate the child. So to make a diagnosis of autism spectrum, after you've screened the child and the child, has this indication that the child is at risk, a severe risk for having autism spectrum based on the MCHAT result, this is the way you diagnose it, okay? A multidisciplinary evaluation is the most beneficial, but the diagnosis can be made by a general practitioner, a pediatrician, a neurodevelopmental pediatrician, a neurologist, a psychiatrist, and a psychologist. And these are the tools available here that you can use. This first one, the Childhood Autism Rating Scale, and then also the formalized screening based on the DSM-5 criteria. These two, the physician can use it to be able to make a diagnosis of autism spectrum. And I will show you what the DSM-5 criteria looks like, okay? So it's based on the definition. Remember when I defined what autism spectrum disorder was? When I defined what it was, I'm sorry. I'm going to go back there again, okay? So when I defined what it was, it has, one is persistent deficits in social communication and social interaction, and it has a list of examples. The second one is the restricted repetitive patterns of behavior, interests, or activities, and it has several examples as well. So you can use these DSM-5 autism diagnostic criteria to diagnose the child with autism. The symptoms must be present in the early developmental period, and the symptoms should cause clinically significant impairment in the child's social or other areas of functioning, and these disturbances are not better explained by intellectual disability or other type of developmental delay. Keep in mind, a certain percentage of children with autism spectrum disorder will also have intellectual disability as a coexisting condition. Then this last testing, which is called the Autism Diagnostic Observation Schedule testing, has to be done by a trained professional. Usually the trained professionals that do this are psychologists, and then other neurodevelopmental pediatricians like myself have been trained to use this tool. But here in Jamaica, I've just been using the Childhood Autism Rating Scale, the DSM criteria, and I use the MCHAT, to make my diagnosis. So the next slide shows what are you going to do after you make the diagnosis or you suspect the child has autism spectrum disorder after completing the MCHAT on this child. You have medical intervention, behavior intervention, child education, parent education training and support, and then also we should not forget the siblings who may get left out in the process, sibling support. So medical intervention should include sending them for a hearing test. This is very important because you do not want to make a diagnosis of autism spectrum disorder in a child that is deaf. You want to make sure you document that the child does not have a hearing loss when you diagnose autism spectrum disorder. Also, these kids tend to have gastrointestinal problems, feeding problems, and sleep issues that you will need to help them with. The behavior intervention that is specific and has been proven scientifically to work well in children with autism spectrum disorder is the ABA, which is applied behavior analysis therapy, as well as other therapies based on the principles of ABA. So this is, very helpful in helping them behave better. And then because they tend to have language delay, large percentage of them have language delay, you want to refer them for speech therapy. So what do you do? Early intervention to educate the parents and also to educate the children. You want to start as early as 18 months of age. Once you suspect that this child may be on the spectrum, you start to advise the parents on what to do to educate this child so the child can start to get better with the autism spectrum. So you want to advise the parents to reduce screen time with the TV and with electronics for the children. Because especially in the past year and a half with COVID, a lot of toddlers have been spending a lot of time watching the TV and a lot of time on the tablet and on the cell phone, just playing games and watching things on these tablets and the cell phone. And this has really significantly impacted their language development in a negative way. So you advise the parents to reduce the screen time and advise the parents instead to spend more one-on-one time reading books and interacting with their children to develop the children's joint attention and pointing skills. For those who are the children that are 2 to 3 years of age, the goal is to send them to school. You suggest to the parents, and a lot of preschools, nursery schools, basic schools, and daycare centers are open now. You suggest to the parents, if the child is between 2 and 3 years of age, to send them to school so that the school can provide the child with structure and methods to facilitate social skills, functional communication and learning, and also exposes these children to typically developing peers to be used as role models and playmates. So the resources, because this is one of the things I promised to provide, is the resources for children with autism spectrum disorders here in Jamaica. I have provided an exhaustive list of the hearing test locations, speech therapists, ABA therapists. Mostly they are here in Kingston. That's where most of these therapists are based. And this exhaustive list has been sent to the AGPJ office through Dr. Gordon, and you can get it there. They can email you the exhaustive list. And I'm still in the process of adding some more to this list, as I am trying to collect all these resources from all over Jamaica, not just mainly Kingston. Most of these resources are available mainly in Kingston, but I will collect the ones from other parts of the island. I also have reliable websites for parents on the management of autism spectrum disorders that I have provided, as well as the schools. So now I am going to go to the next presentation on ADHD, and I will pause my screen. All right, so now I am going to go on to talk about ADHD, and that is me again. So I am going to start my ADHD presentation by giving you 4 case presentations, 4 cases of the different ways that ADHD can present in children. The first case is a 6.5-year-old in grade 1. He was born premature, one of twins, at 32 weeks of gestation. He's receiving speech therapy. And then in the classroom, he acts immature, hyperactive, inattentive, and impulsive, and difficulty with reading. So that's the first case. These are actual cases that I have had in the past. The second child is a 5.5-year-old boy in kindergarten with hyperactive behavior. He's doing well academically, but does not like to write or copy shapes. He does not yet have hand dominance. His 14-year-old brother has ADHD and is getting extra help at school with reading. His father has attention problems, but no formal diagnosis of ADHD. The third case is a 7.5-year-old boy in grade 2, diagnosed with autism at 2 years of age and has attended school since then. Now he's in primary school, he's having social skills difficulty, he talks a lot and has difficulty remaining seated in the classroom. He's also aggressive. The fourth case is a 6.5-year-old boy who's one of 6 children in his family. His father is unemployed and his mother just had another baby. The family have moved homes 6 times in 3 years. There's conflict and disorganization at home. The child has attended 3 different schools, and now in grade 1, he's getting extra help at school with reading. He gets angry easily. He's very active and disruptive in the classroom. So these are 4 different ways that ADHD can present. So what is ADHD? It is the commonest behavior disorder of childhood. The worldwide prevalence estimates for school children, for school-age children, the estimate is 0.1 to 8%, with a mean of 2.2%. In Jamaica, the most recent current statistics obtained in May 2010 in a study done by Audrey M. Pottinger, PhD, at the Markham Child Care and Development Center in Kingston, showed an ADHD prevalence in Jamaica of 3% in school-age children. Worldwide prevalence is greater in males than females, and it ranges anywhere from a ratio of 3:1 all the way up to 10:1. ADHD is a disorder that peaks in middle childhood, and middle childhood is age 6 to 11. It is a disorder of response inhibition and executive functioning or self-regulation. What part of the brain is affected? There are 2 areas. The parts of the brain that control movement, which is the basal ganglia and the cerebellum, and the parts of the brain that control attention, which is the anterior cingulate gyrus and the right frontal region. The neurotransmitters present in these areas of the brain are dopamine and norepinephrine. How do you diagnose it? Currently, ADHD can be diagnosed in children as early as 4 years of age, and it can be diagnosed in adolescents all the way up to 17 years of age. It is more commonly diagnosed in middle childhood, as I said, which is when the symptoms peak between age 6 to 11. How do you diagnose ADHD? First, take a good history. Next, very, very important, get behavior rating forms completed by the parents or guardians, as well as the teachers at school. So which is the easiest behavior rating form out there that's easiest to score for all types of physicians? This is the NICHQ Vanderbilt Assessment Scales, and it's also commonly called the Vanderbilt Behavior Rating Forms. I've used these Vanderbilt Behavior Rating Forms for many, many years, and I find it very, very helpful. So it's copyright from the American Academy of Pediatrics and the National Institute for Children's Healthcare Quality. It's used to aid in the diagnosis of ADHD. And just like the MCHAT, it can be downloaded for free at the NICHQ Assessment Scales website. And the download also includes scoring instructions. So this is what it looks like, okay? It's called the NICHQ, as you can see, used for diagnosis of ADHD. This is the parent form. So this is the one, you download it, have it available in your office, give it to the parent to fill. It's 2 pages, front and back. And what the parent is to do is to circle what the appropriate, for each of these symptoms, to circle the appropriate severity for their child for each of these symptoms. And the symptoms that you're going to be, the numbers you're going to be looking, you're going to be counting to diagnose ADHD is numbers 2 and 3, which is often and very often. So the parent fills out this whole thing. The first 9 questions are inattention questions. Then number 10 to number 18 are hyperactivity, impulsivity questions. Number 19 to number 26 are oppositional defiant disorder symptoms. Then number 27 all the way to number 40 are conduct problems. Number 41 to 47 is anxiety/depression symptoms. And then the second page has performance, And in performance, what you're looking at to diagnose ADHD is number 4 and number 5, severity 4 and 5, which is somewhat of a problem and problematic. And then the very bottom of the second page shows you how to score it. So this is very useful. You just need a parent behavior rating form and a teacher behavior rating form. The teacher behavior rating form is similar to the parent one on the first page. The only difference is on the second page for the teacher behavior rating form, the performance section is divided into academic performance and classroom behavior performance. And in the same way as the parent one, you're looking for symptoms 4, severity 4 and 5. Okay? Then these are the follow-up behavior rating forms. There's the parent follow-up behavior rating forms, and there's the teacher follow-up behavior rating forms. So I find these very useful in diagnosing autism spectrum and ADHD. So how do you make the diagnosis? The symptoms are in 2 domains, inattention and hyperactivity impulsivity, as I showed you on the behavior rating form. There are 3 subtypes: inattentive subtype, hyperactive subtype, and combined subtype. In the past, there used to be a type of ADHD called ADD. Right now, according to DSM-5, that does not exist anymore. All ADHD is ADHD, and then you either add inattentive type, hyperactive type, or combined type, depending on the severity, on what you scored on the behavior rating form. So for inattention, it requires, when you count how many 2s and 3s the parent has, for the first 9 questions, you need at least 6 out of 9 to fit the criteria for inattentive subtype. Also for hyperactivity, you need 6 out of 9 of the hyperactive symptoms to be 2s and 3s. And for the combined type, you need a total of 12 of 2s and 3s in the first 12 symptom questions. To also make the diagnosis, these symptoms have to be maladaptive and inconsistent with the child's developmental level. They have to have been present before age 7 and have to have been present for at least 6 months. And these symptoms should result in impairment in at least 2 settings. For children, it's school and home. And for older children, it may be work setting as well. And there has to be significant impairment in the child's social, academic, or occupational functioning because of this condition. And the symptoms are not better accounted for by another mental disorder. These are the coexisting conditions that tend to occur in addition to ADHD in these children. 2/3 of children diagnosed with ADHD will have one or more of these coexisting conditions. The externalizing conditions are oppositional defiant disorder and conduct disorder. Internalizing conditions are anxiety, depression. Learning disabilities tend to be pretty common in these kids. Speech and language impairments, they have them. And then motor disorders, these kids have poor handwriting. They have visual motor integration problems and tend to be clumsy. So when you look at the Vanderbilt, that behavior rating form, it has areas that can help you make these diagnose these coexisting conditions in the child. So in continuation with the history, I'm just giving you a little more detail. You want to make sure you take a birth history, a developmental history, a school history, past medical history, medication history. Family history is very important as ADHD can run in families, and also review of systems. You want to do a thorough physical examination. You want to do a neurological examination, because remember I told you they tend to be clumsy and they can have some motor skills issues. Hearing screening and vision screening is desirable in these kids just for completeness of your evaluation. Blood work only if it's indicated, and same thing, imaging studies of the brain if indicated, and psychoeducational testing, you want to send them for that if you suspect a learning disability or there's learning difficulty with the child. So the management for ADHD is best done in a team approach, where the parent, the teacher, the teachers, the physician, and if the child is receiving any therapies, where everybody works together as a team. This is where you get the most success. And then behavior therapy is the first line management for attention deficit hyperactivity disorder. And this is the definition of behavior therapy. It represents a broad set of specific interventions that have a common goal of modifying the physical and social environment to alter or change behavior. And then medication treatment would be like a last resort. The first line treatment, as I said, is evidence-based parent and or teacher administered behavior therapy. And I will give you examples. Classroom accommodations really is part of behavior therapy, because you have such accommodations such as preferential seating, breaking the schoolwork into smaller parts for the child, and providing periodic breaks while doing classwork. And I've also provided a much broader list of classroom accommodations to the AGPJ office for you guys to be able to obtain. Methylphenidate, which is the commonest psychostimulant medication prescribed for ADHD, can be prescribed if the behavior interventions do not provide significant improvement and there is moderate to severe continuing disturbance in the child's function. Compliance for patients with ADHD is difficult, but to be able to get them to be more compliant, it requires regular follow-up visits, parent education at each visit, because some of these parents themselves may have attention deficit hyperactivity disorder. You want to have the parents bring in completed follow-up behavior rating forms, parent and teacher completed at each visit. You want to have the parents bring the child's progress report so you can review what the progress is being made with the classroom accommodations that have been put in effect. And then you can modify the classroom accommodations as needed. And then also for the parents that need medication management, you can manage them. I have provided all these resources to the AGPJ office. You can get them via email by contacting that office. And I am also still collecting more of these resources all over the island of Jamaica. And then this is me. If you'd like to contact me, this is where I am, at Kids Clinic. And that's my contact information. And I will stop sharing at this time. Thank you.
Indeed, it's a pleasure, Dr. Livingstone. We have all been taken back to school, but I think Dr. Swaby will be on the floor for questions.
Thank you very much. And thank you. Okay, thank you. Thank you very much, Tosan. And we have a few questions here. Let me just go to my screen. And okay, there we go. The first question is, how do you feel about the use of diet and probiotics in the management of autism? That's by Douglas Street, asked that question.
Okay. In terms of the use of diet, can you hear me?
Yes, very well.
Okay, so in terms of the use of diet for management of autism, what I tell parents is that as long as the diet that they're using, whatever diet they're trying to use, is safe, because remember, these children are still growing. So you do not want to provide them with a diet that's going to be harmful to their growth. So as long as the diet that they're using is not interfering with the child's growth and provides the essential nutrients that the child needs to grow, I do not have a problem with parents trying to use any, a type of modified diet to see if the symptoms will get better. And what I tell the parents is to do a before and after. Like when they're using a specific diet, you want to document what the child's behavior was like before the diet was started. You want to give it a few months of the diet. And then at the end of that diet, you want to check what's the child's behavior and has there been any improvement. If there has not been any improvement on the child's behavior or development as a result of using that diet, then there's no point continuing with that diet. So as a pediatrician, as long as it's not harmful to the child, I do not have a problem with the children, with the parents trying it. In terms of probiotics is good for all children, and just as I said, autism spectrum children tend to have a lot of gastrointestinal problems. So they can try the probiotics. If it benefits the child, then continue using it. And if it doesn't benefit the child or make a difference in the child's behavior or development, then there's no point continuing it. So that's usually what I tell the parents. I always do a before and after. And when I see the child after several months of them trying the diet, I show them, this is the progress the child has made, and they can see themselves whether the child has made any progress or not. I hope that answers.
Fantastic, thank you. Next question is hearing disorder associated with autism?
Okay, thank you for the question. In my practice of seeing these kids for many, many years now, a lot of the children, I send them for hearing tests, but most of the time the hearing test is normal. So hearing disorder is not associated with autism. Their hearing most of the time is normal. And then what happens is children who are deaf, can have some symptoms that look like autism spectrum. But if they are evaluated by a professional that has experience, you can tell that children who are deaf do not tend to fit the criteria for autism spectrum disorders. So they tend to have communication. They're able to communicate. They find other ways to communicate. While children with autism spectrum disorder will not, it's hard for them to find ways to communicate. So I would say the answer is that no, it does not.
Okay. I'm gonna go, okay. Let me just go to, so does stammering have anything to do with autism?
Okay, just as I said, children with autism have language problems. They have language disorders. So stammering is a language disorder. It's a fluency disorder. So just like with any child with language disorder, children with autism spectrum can also have a language fluency disorder, which stammering is. So it can present in them, but it is not part of autism spectrum disorder.
Fantastic. Okay, in the interest of time, I'm gonna ask you if you can answer the rest of the questions in the question and answer section. Just go to the ones that have not been answered, and if you could answer them online.
Okay.
And the overarching request is that we would like to be able to get a copy of your slides, if that's okay with you.
Yes, I have already presented them to Mr. Samuel Heron, the model. Yeah, he has them.
Okay, so he can send on. Dr. Livingstone, thank you so much for your presentation. It was clear and concise and very, very informative. Thank you again.
Thank you. Thank you.
Back to Raymond.
Thank you, Dr. Swaby. Good to have you on again. The task finally have been placed for me to have another speaker, but before that, I think we should, I may be corrected, have another sponsor's presentation about nutrition. Do we have Paul Russell?
Yeah, the slides will be queued up in a second. Thank you, Dr. Notis.
Okay.
Life doesn't stop for diabetes. Be ready for every moment with Glucerna. It's the #1 doctor-recommended brand that's scientifically designed to help manage your blood sugar. Live every moment. Glucerna.
As a clinician, helping your patients make the right decisions is a daily task. Glucerna shakes provide nutrients to help your patients support their immune health. Replacing a usual breakfast and a snack with Glucerna Hunger Smart resulted in a 50% reduction in the positive blood glucose area under the curve after breakfast. Glucerna contains Carb Steady, which is a scientifically designed blend of slow-release carbohydrates which allow your patients to maintain more consistent, balanced blood sugar throughout the day. Because many of your patients make poor choices or they may miss breakfast and lunch altogether, Glucerna provides a better meal choice with more protein, key vitamins and minerals to support the immune system of your patients. Glucerna is available in all major supermarkets and pharmacies and is distributed by Carmen.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
Life doesn't stop for diabetes.
That's it for the presentation from Abbott. Back over to you, Doc.
Thank you much, Paul. We really appreciate your presentation. Asking our attendees to stay on board because we anxiously await the discussion, which will be carried on by Dr. Lisabeth Crossman. Of course, she's a psychiatrist, having received her medical training at the University of the West Indies, Mona. She's currently employed for the past 15 years in the western region of the island of Jamaica, and currently is the regional psychiatrist. And of course, her responsibilities are wide. She responds for the administrative and clinical mental health in that region also. She is proud holder of a master's trainer for the Universal Treatment Curriculum in Jamaica and was certified in 2019 as a member of the International Society for Substance Use Profession in Vienna, Austria. She is a captain, very unusual, but very grateful for that, in Jamaica Combined Cadet Force Commission in 2013. She's involved in the church as well as the wider community. I may tell you, she is married, she's a family woman, and so much so to a very good friend of mine, Dever Nugent from Sherwood, there before Mr. Bolt. But help me welcome Dr. Lisabeth Crossman.
Okay. Thank you, Dr. Notice. Are you hearing me quite well?
Quite so.
Great. Thank you very much. Didn't know that you know so much about me, but we'll discuss it at another time. But thank you very much, Dr. Gordon and team, for inviting me to be a part of this program. I'm going to start sharing screen in the interest of time. Okay. So my topic is going to be looking at the causes and management of acute psychotic disorders in general practice. So we're going to start briefly looking at an outline. We want to look a little bit on the definition of psychosis, some pathophysiology, causation theories, primary versus secondary psychosis, and of course, the management of our psychotic disorders. Now, there's still controversy about what is psychosis, how we define it, what do we consider to be the syndromes or the symptoms that exist to call and this a psychosis. So it is loosely encompass the spectrum of diagnostic syndrome, which we have schizophrenia and the related disorders, the affective psychosis, of course, the substance-induced psychosis and withdrawal states, psychosis caused by somatic disorder, that's your medical conditions, as well as psychotic states associated with the neurodegenerative disorders such as dementia, Parkinson's disease, and Huntington's disease. Now, when we speak about psychotic symptom versus psychotic disorder, we need to remember that not everybody that has a psychotic symptom will end up having a psychotic disorder. Case in point, I'm sure that many persons have had persons coming to them saying that they have had hallucinatory experiences. Not all persons having hallucinations will be experiencing a psychotic disorder. So we need to be very clear about that. So the definition I'll use today, which has caused a lot of controversy still, we're going to be using that psychosis is a condition that features a range of behavioral alterations that relate to a loss of contact with reality and a loss of insight. And we're saying that people with psychosis are going to be experiencing hallucinations, primarily auditory in schizophrenia, and delusions. Now, hallucinations, remember, these are perceptual disturbances, and these can affect, if you remember, you have the 5 senses. So all these senses can be affected by hallucinatory experiences. But we are speaking about the auditory one, which we can see mainly in your patients diagnosed with schizophrenia. Now, if we use the Diagnostic Statistical Manual of Mental Disorder, we are now up to 5. The psychotic disorders that you will find there are schizophrenia, your brief psychotic disorder, your schizophreniform disorder, your schizoaffective disorder, delusional disorder, the shared psychotic disorder due to a general medical condition, or psychotic disorder due to another medical condition, as they put it, the substance-induced psychotic disorder, and what is known as the other specified schizophrenia spectrum and other psychotic disorder. Now, because we are going to be, a lot of the studies surrounding psychosis actually came from studies with schizophrenia. And so most of the presentation will be looking at schizophrenia as the prototype, for want of a better word, and then we'll branch out to look a little bit at how psychosis and the other medical conditions will probably look and how we can manage these disorders. Not to forget that our medical disorders that can present with psychotic symptoms, so your neurological conditions such as your stroke, epilepsy, mainly temporal lobes, sorry for the misspelling there, Huntington's, Pick's disease, your Alzheimer's disease, your multi-infarct dementia, which we are seeing a lot of, the leukoencephalopathies, the multiple sclerosis, and of course, migraine headaches. And these are rare in migraine and the multiple sclerosis. All right, one of the etiological or the mechanisms related to etiology is what is known as a complex gene environment interaction. And it both influences the appearance of the symptoms as well as the persistence of the symptoms. And we like to say in psychiatry that we have a biopsychosocial and we put in cultural overlay or overlap that happens. And so there's no single pathway that is responsible for the range of the disease or the experience that the individual will have from the psychosis. There has been a lot of studies looking at the interplay between the genetics, the epigenetics, the exposure to childhood trauma, which is really a very interesting and challenging topic for us, and the experience of the suboptimal environmental factors that can cause activation and later cause the pathologization of the psychosis. Now, schizophrenia is what we would term a silent lesion in the brain. Silent because most times it really presents unexpectedly, and of course, there is nothing anatomically most times that persons will see. It's a disconnection or abnormal connection between the frontal, temporal, and parietal lobe, and we look a little bit more into that. And we mentioned it has been caused by different factors, and there may be some disturbances in the prenatal and early postnatal period. And of course, there may be structural and functional abnormalities that we will be able to talk about a little later. Now, when we speak about hallucinations, one of the hallucinations that has been studied a lot has been auditory hallucinations, and this psychosis or psychotic symptom that most persons allude to have been shown to be associated with altered connectivity between the hippocampus and the thalamus. Now, that's very interesting because what is observed that during hallucinations, you have an increased activation of the thalamus, the striatum, and the hippocampus. And this alteration with this connectivity, especially in the hippocampus, may impede the internal and external representation of the auditory processing. So whatever is being processed is not coming across very clearly. Right. And delusions, in contrast to the hallucinations, have been shown to be associated with the overactivation, of the prefrontal cortex and diminished deactivation of the striatal and thalamic network. So this diagram gives a little bit of insight as to how it is thought to happen. If you notice that the prefrontal cortex and the thalamus, there's a communication there, and this expression will affect the associative striatum, which is where your basal ganglia and all these, the caudate nucleus and all of these things all interact together. And the pathways, you're seeing the dopamine pathways being there as well, and also the hippocampus and the amygdala feeding into the thalamus. So all of this interplay is happening, and albeit you have a lot of different theories and a lot of different suggestions now, there is still the suggestion that this alteration in the expression and the interplay between these structures in the brain can result in these psychotic symptoms. So we have a multifactorial etiology. There's a genetic, there's a neurodevelopmental, the epigenetic, and the cognitive model. And we just briefly go through them, because if we are going to have some impact on dealing with psychosis and what is happening, we have to have some understanding as to how these different factors interplay and how we are able to aid the management of these conditions. So this is a genetic, and basically what it is saying is that the studies have shown that the closer persons are in sharing genes, the more transmissible, for want of a better word, or the risk of developing schizophrenia increases. So in the general population, we are saying that persons, it's a 1%, the epidemiology is 1%, that the persons will have the disease. But as you increase in terms of the relatives, how close you are in terms of your relatives, we can see that the risk of developing schizophrenia increases to the point where the identical twins, there's a 48% of the other twin developing schizophrenia. The other component to the gene, and this has been borne out in our family studies, looking at twin studies, looking at monozygotic versus dizygotic, and also in our adoption studies. The other changes that we can see, we may see enlarged ventricles and reduced tissue volume as a part of the anatomy, the neuroanatomy. And there is also what is proven is that the frontal lobes, which have more of your cortical functioning, has less active in your major dopamine pathway, so the hypofrontality. All right, in terms of your stress model, the diathesis stress model, this proposes that there's with the precursors and the vulnerability and different stressors, the outcome is going to be a psychosis or disorder of schizophrenia. So whenever you have these factors coming into play and impacting on the individual in negative ways, then the outcome is going to be schizophrenia. I'm sorry, the slides got a little bit mixed up, but these actually are the genes that are responsible for playing a role in schizophrenia. Of note, we have the catecholamine methyltransferase, a lot has been spoken about that, the neuroguanine, and all of these other gene mechanism. In terms of the epigenetics, what are the social influences? And this has become a very hot topic because we are seeing a lot in terms of how our social and psychological interactions and social and psychological situations impact on individuals. And these impact on individuals can result in the different stressors and so causing different changes in the brain. And these changes in the brain can therefore result in the impact it has on the function of the individual and result in the psychosis or psychotic disorders. So we may have activated underlying vulnerabilities with an increase in relapse. You can have the family interactions that can cause stress. You can have, and that can be shown in families of people with schizophrenia, showing very ineffective communication pattern, the high expressed emotion in the family, which is associated with relapse, and of course, substance use and misuse. And that can come across, this has been touted to come across because individuals may actually use these substances for self-medication. In terms of the cognitive model causes, the thought is that, and I heard Dr. Prescott spoke about the filtering process that we all have, how we filter things out of our brain. And there are certain things that become important to us. There are certain things that are unimportant. And because of that, these unimportant things really don't bother us. And so we carry on with life. But in the person with schizophrenia, even the neutral stimuli can lead to inappropriate perceptions, thoughts, and behaviors. And of course, impairment in working memory and problem solving. And these can affect how the individual behaves, or the individual produces their thoughts, how they function, and that can impact on the individual themselves. So this is an example, or this is one of the models looking at the how these situations impact on the individuals. So if we look at the genes and how it impacts on the neurodevelopmental, as well as the neurodevelopmental hazards impacting, they cause a sensitization in the dopamine system, and therefore there's what is called the biased cognitive schema that can result from the social developmental adversity. And if we continue downwards, we can see how this biased cognitive schema, based on how we are interpreting things, can now feed into how we have processed the stimuli, because we are now not able to filter properly. And because we are not filtering properly, then we can now get a paranoid interpretation, and that can lead to psychosis, which can then create now a vicious cycle, creating the acute psychosocial stress, and then continue on in that manner. There's also the stress vulnerability bucket by Graban and Turkington. And what this model shows is that whenever the threshold of stressors exceeds the individual vulnerability level, then the individual is unable to function very well, and they become a little bit unstable. So this is what it shows, is that we have vulnerabilities. And what are these vulnerabilities? These are things from our past that we really can't change. So the genetics or biology, the cognitive and mental abilities, the adverse childhood experiences or the early life experiences, we really can't change these things. And these make us more at risk or become sensitive to stress or become unwell. So we have these vulnerabilities, which is the bucket. Then we are now going to pour into the bucket other things. So depending on what is happening to us, how we are dealing with whatever stressors, whatever the bereavement is, we just had COVID. So if we think about the deaths during COVID, the unemployment, not being able to go to work, not being able to go to school, not being able to socialize very well, then these things now are adding now to our vulnerabilities. And of course, adding to the vulnerabilities, we must remember that positive events can also be stressors. So getting married, getting a new car, getting a new job, getting elevated, getting promoted, these are things that are stressors as well. And these stress factors now is going to be determining the amount of, let's say, water that gets into the bucket before the illness. So we are adding now water on top of water. And what tends to happen? And I mentioned the social determinants of health here because we cannot forget how these conditions impact on individuals and impact also on the stressors that we are speaking about. So whenever we have coping strategies and good coping strategies, then the tap can open, or if there are holes in the bucket, then water will flow out. But if we are unable, or if it is impossible to remove these corks from the bucket or to turn on the pipe, then what tends to happen is that there's an overflow. And this overflow leads to the psychosis. Another thing that we need to pay attention to and look at is some of the pathways that are involved and the symptoms of schizophrenia. We made some allusion to it a little bit earlier. We alluded to it, the mesocortical pathway, and that is now dealing with your cognition and executive function. We have the mesolimbic pathway, the regulation of emotional behavior, and you have the positive symptoms coming in here. And you have the nigrostriatal pathway, which is your motor control, and your tuberoinfundibular pathway, which is your regulation of prolactin secretion. Now, all these pathways are major dopamine pathways, and dopamine is one of the neurotransmitters that was studied earlier and was thought to be earlier the only pathway, although more pathways have developed and more has been spoken about the other pathways. But most of our drugs, and especially the older medication, operates through these pathways. And because they operate through these pathways, then we are going to be dealing with some of the symptoms and dealing with some of the medications that will cause some side effects based on how they are interacting in these pathways. So again, the same problem, the same pathways, giving the different symptoms. The other pathways that I mentioned, that like serotonin and the other neurotransmitters that are important, the glutamate, your GABA, your acetylcholine, and of course your inflammatory transmitters as well. So these are very important when we are managing psychotic disorders. We just mentioned those. So very important, we need to recognize then that when we speak about psychosis and the interaction and the interplay between the different factors, the genes, the developmental factors, the social adversities, then we are going to see how silently this disorder can move and how schizophrenia can move throughout the different periods of life. And most persons will start showing symptoms between the adolescent and early adulthood, because now the social adversities and the vulnerabilities and now the stressors become so predominant that persons are unable to probably hold it in, and therefore we have the psychotic symptoms. All right. So when we are going to manage, it means that we have to look at how do we assess? And based on how we assess and based on our diagnosis, then we are going to apply the different therapeutic management. Very importantly, when we speak about acute episodes, the emphasis of treatment is on providing safety. We're going to identify contributing factors, and we're going to implement pharmacological and psychosocial measures for the resolution of symptoms. And for the first episode, we might have challenges because there may be some clarifying of the diagnosis. Sometimes we may not get a good history at all. We have to go into psychoeducation, and we have to establish rapport with the patient and their family. We also need to remember that psychosis is not a diagnosis that anybody wants. And so a lot of times families and patients withhold information, and so we have some challenges there. So a detailed history, if possible, because sometimes we may not have the time, depending on the acute nature of the presentation, to get a detailed history. Physical examination to include neurological examination or mental status examination. And for some persons, we may have to do a mini mental status examination. And of course, our investigations, blood, radiological, and otherwise. Now, I put here the diagnosis for schizophrenia because if we understand the diagnosis for schizophrenia, then we will be able to exclude other conditions. So we always say that the schizophrenia is a diagnosis of exclusion, would have excluded all medical conditions, would have excluded all substance use and any other conditions that may present looking with a psychotic illness. So we have different criterion for the disorder. So A, you must have at least one or two. You must have at least one, and one of the conditions that I'm going to speak about, and this must be present for at least a significant portion of time during a 1 month period, unless it is treated successfully. So the delusions, the hallucinations, the disorganized speech, grossly disorganized or catatonic behavior, and the negative symptoms. And of course, for a significant portion of time since the onset of the disturbance, the level of functioning is going to decline. So we notice that the patient is not doing well at work, or the interpersonal relationships are very disorganized. They are not taking care of themselves. So hygiene is not being met. They're not taking care of their surroundings. So this becomes the level of functioning becomes very important in making this decision. We also look at if they're going to school, what is happening in school. So they are not doing well. So they are failing, or their expected level of achievement is not as before. So there's a decline in the interpersonal, the academic, or the occupational functioning. We are also saying that for this disorder, the disturbance must last for a 6-month period, and it must include 1 month of the symptoms. And this is schizophrenia. And that means that the active symptoms may be there, you may have prodromal or residual symptoms. And the significance during this prodromal or residual period, the disturbance may be manifested by only negative symptoms or by 2 or more of the symptoms listed above, or they can present in attenuated form. Example, odd beliefs or unusual perceptual experiences. So that's criterion C. Now D is where the schizoaffective disorder, you have now ruled out all mental disorders, and so it must meet no other mental disorder, because either there are no major depressive or manic episodes, so we have ruled out the schizoaffective, depressive, or bipolar disorder, or if it is a mood episode, they have occurred during the active phase of the symptoms, and they have been present for a minority of the total duration of the active and residual period of the illness. And we have also ruled out any physiological effects, whether it's due to a substance, whether a medication, or any of the substance or drug of misuse, or it is due to another medical condition. So we have ruled out everything. And for schizophrenia, the other rule out is if there's a history of autism spectrum disorder or communication disorder of childhood onset, then the diagnosis is only made if there are prominent delusions or hallucinations in addition to the other required symptoms of schizophrenia, and it must be present for at least a month. So these are the rule-out conditions. We now have to look at what would be the medical conditions and how we rule those out in DSM-5, and what does DSM-5 says about a psychotic disorder due to another medical condition. So one, we look for prominent hallucinations or delusions. We look for evidence from history, physical examination, or lab findings that the disturbance is a direct pathophysiological consequence of another medical condition. And of course, the disturbance is not better explained by another mental disorder. So this would be a psychotic disorder due to another medical condition. We have also ruled out it is not occurring during delirium, and the disturbance must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So how do we manage these individuals? We mentioned before that we would have taken a detailed history, we would have done our investigations, would have done our assessment. So we have reached a point where we are saying this person has some psychosis and we need to treat the individual, whether the psychosis is due to an underlying medical condition or underlying psychotic disorder. So in treating the psychosis, we have what we call the first generation antipsychotics. And these antipsychotics mainly impact on your dopamine receptors, and mainly your postsynaptic dopamine receptors. So chlorpromazine, known as also as Lagactil, which we know. Thioridazine is not used anymore. Meloril, some persons may remember Meloril. Flufenazine, which we know in the depot preparation as Modicet, and we also have haloperidol. So these are just some, because we also have, some persons may know stelazine, trifluoperazine as well. So these this first generation antipsychotics do have side effects, and the side effects is actually dependent on this, based on their potency and how they bind to the receptors. So your chlorpromazines are low potency, and with your compared with your haloperidol, which is a high potency. So for your low potency medications, you will find that the extrapyramidal side effects, and we spoke about how your dopamine interactions in terms of the pathways in dopamine and how they interact. So you can look at those interactions and see how they would interact. So your chlorpromazine would have low potency, and so low extrapyramidal side effects, but of course, it causes a lot of sedation, it causes a lot of cholinergic problems as well, and it also can impact on your histamine and reduce your blood pressure and cause hypotension. When you compare that now with your haloperidol is high potency. So your haloperidol is going to have less antipsychotic, but it's going to have more anticholinergic rather, but it's going to have more of your extrapyramidal side effects. So those are some things to bear in mind with your first generation antipsychotic medication. When you look now at your second generation antipsychotic medication, and this gives you a good view of how we can compare across the board in terms of what they do. The ones that we have here, we have our olanzapine, we have paliperidone, we have quetiapine, we have risperidone, we have ziprasidone in some areas, and clozapine. And these second generation antipsychotic not only impacts on your dopamine, but also impacts on your serotonin receptors. And this becomes very important because it means now that your side effect profile is going to be a little different or much different from your first generation antipsychotic medication. And most of the side effect is going to be in your weight gain, in your dyslipidemia. So these are most of the problems that you're going to be seeing, your metabolic side effects, especially with your second generation. Not that it cannot occur with your first generation, but most of your second generations will have those effects. Very interestingly, we now have the depot preparation that we use a lot in your second generation, and depot is your slow release injection that is given sometimes once a month, sometimes once every 3 weeks, depending on the type of medication that you're using. So we have the risperidone Consta, so the risperidone, and we have the paliperidone, the Invega Sustenna, and now we have the 3-monthly Invega Trinza. And one of the inhibiting factors in using some of these medication, especially if you're not within the government system, of course, is going to be the cost of the medication, because they're very, very expensive. Clozapine is still the drug of choice for the treatment-resistant schizophrenia, those persons who we have treated and have tried on a sufficient dose of your antipsychotics and they're not improving. The second generation antipsychotics as well is also used a lot in persons with medical complications presenting with a psychotic disorder. And that is because of the side effect profile again, and because most of these patients are going to have taking a lot of other medications. We also have to look at drug-drug interactions. And so we'd want to minimize the number of medications that they are on. Okay, so we spoke about the drug-drug interaction. It's very important that we pay attention to that because sometimes it is the drugs that are causing the problems in the individual, but also we may need to use an antipsychotic to help individuals who are not doing well, and that is contributed. The psychosis is because of is caused by a medical condition. One of the things that we need to consider is how do we prevent persons from getting back to a psychotic state, because why we need to do this is that every time an individual gets ill from a psychotic illness, it means that they're going to take more medication, they are going to take a longer time to get well, and some persons may not recover at all, may not come back to their normal state. And that is because of the destruction of brain cells that happens every time that there's a relapse. So we want to prevent these relapse from happening. And that's the importance of ensuring that we have done our due diligence and ensuring that we have taken a proper history and we have done all the interventions necessary to have ruled out preventable or a treatable psychotic illness that is not schizophrenia. We want to also look at the treatment with antipsychotics, ongoing treatment. Is that going to be necessary depending on what is happening with the individual? And if it is necessary, it means that we are going to have to ensure that this relevant and the important psychoeducation is done, not only with the client, but with the family. And the psychosocial interventions are very critical because we want to continue adherence to treatment. We want to manage any stressor to the psychosocial framework of the acute episode, and we want to support return to school or work or to whatever occupation they have been doing. So we want to look at the side effects of medication, their diet and exercise. And we also want to encourage vocational development, because remember that sometimes some of these individuals may actually be impacted in their adulthood and adolescent and early adulthood phase of life, and therefore they may not have had the opportunity to finish their schooling. And so we want to enable that development to occur in enabling them on the road to recovery. So all of this is dealing with recovery. So psychoeducation becomes important. Psychotherapy also becomes important. Supportive care, a supportive psychotherapy. What can we do to support the individual, not only during the acute phase, but throughout during coming to us during the journey, the period of getting well, of recovery and beyond. And the cognitive behavior therapy is one such therapy that has been shown to be that has been shown to improve individuals, even in the first episode and the early stages of their psychotic illness. Social skills training, the family intervention, and what we call the community psychiatry day hospital, because this is where the individuals can have that interaction with their doctors, with their nurses, with their psychologists, with their social workers, with their therapists, their art therapists, or their other therapists, and that enables them to move from a state where they don't think they can function very well in community to be able to function very well in community. And rehabilitation becomes very important, because what we want to do is to ensure that we are optimizing any psychosocial outcome. We are going to ensure that we are going to be vigilant in regarding relapse prevention. So we are looking for signs and symptoms that will point us towards that this person is not doing well, and we want to prevent those relapses. We want to meet educational goals in terms of vocation, and we want to pay attention to the long-term health maintenance issues. The outcome is going to be dependent on the cause of the psychosis. And so psychoeducation becomes important. The follow-up of the patient becomes important. And we're going to try to manage any underlying triggers. We may not be able to move the person out of their community, but probably we can give them better coping skills to deal with whatever situation they have. And we also want to look at how we can support them in engaging them and engaging other agencies to be able to manage some of their underlying triggers, whether it is substance use and looking at how the National Council on Drug Abuse can help, whether it is housing solutions and seeing how we can get the Ministry of Social Welfare and so forth to help, engaging our faith-based organizations, engaging our non-governmental organizations. So if we have the input of all these individuals and all these connections, these services that are available, then we are able to help the individual to have a more favorable outcome. Of course, we want to look at medication as well. If the individual has another medical condition, how we ensure that the individual is stable, because most times if we have the medical condition stable, it will prevent the psychosis, and therefore there would be no further need in most instances for the antipsychotic medication. So for schizophrenia, we want to ensure that the acute phase treatment is followed up by the recovery phase. We want to ensure that positive symptoms will not return, and we want to eventually ensure that patients will experience less severe psychotic breaks and their functioning will be overall decreased compared with what is happening. So their premorbid functioning will be much better. It is not a crime to seek help. And a lot of times when persons present to us and we become overwhelmed, we can reach out to our colleagues, we can reach out to our psychiatric institutions or mental health services, so that we are better able to manage the individual and we are better able to ensure that their recovery, their journey to recovery is quite good. Because the longer that we stay to manage the individual, the worse the outcome will be. And it means that this individual will not have a good prognosis, and it will impact not only on the individual, but the family and of course the rest of the community. These are my references, and I want to thank you for your attention. Hope you haven't fallen asleep on me, and remind us that there is no health without mental health. Thank you very much.
Thank you, Doctor. And without further talk, we will continue with question and answer to be led by Dr. Swaby.
Thank you, Ramoth. And I'm going to share my screen. Okay, excellent presentation. And we have some questions here. Says here, from what age can psychotic disorder or schizophrenia be diagnosed?
Okay, so remember that your psychosis is anybody presenting with hallucinations or delusions or other, they can meet the criteria. Interestingly, a psychotic disorder can be, I'm going to say at any age, but I'm going to also say that the age for, let's say, schizophrenia, if we're talking about schizophrenia, it means that we are looking more at your young adulthood. So we are looking at the impact of illness from, let's say, 16 years and up. Interestingly, we are seeing earlier ages being diagnosed with psychotic disorder. And that is because, as we mentioned before, we have the impact of the vulnerabilities and the stressors and what is happening with the use of substances as well. We can't forget that, all right? So we are seeing them being diagnosed earlier and earlier. There is also what is termed the very early onset schizophrenia, that you can see in children as young as 6 years old. So we can see those, and as I said, the history becomes very important, because you know that children have a lot of imaginations, imaginary friends, and they will be able to say that I'm hearing this or I'm seeing that. And so the distinction has to be very accurate, because you're not going to intervene quite early. The other things that we need to consider is what can also cause psychotic symptoms in children. So very interestingly, I shared the story that in our child guidance clinic, a mother came because her 5-year-old son was seeing a man, and that prevented him from using the bathroom. So he would be very stiff and wouldn't want to use the bathroom. He was not eating. He had stopped talking. He had stopped being his normal self. And she was unable to give any particular stressor as to what was happening. I mean, he was on online school, and, you know, he had a little difficulty, but that did not account for the severity of the symptoms. But on questioning him, I recognized that he also suffers from asthma. And she mentioned that, you know, she would come very frequently to the emergency room because of this asthma that he would suffer from. But her neighbor decided to give her a very good asthma inhaler that she said it was so good that for about 6 months, she had not taken her child to the emergency room. And then she turned to me and she said, well, you know, Doc, it smelled so much like weed. I said, what are you talking about?
Oh my goodness.
And she said, it is called asthma salt. I said, no, that is not it. She said, Doc, it smelled like weed. And of course, I had to look it up. So these are some things that can happen. And I'm sure the pediatricians can tell you that they have seen children who may have come in because they may have ingested some marijuana brownies, or they may have smoked some weed, or they may have ingested mother's tablets. And so they present with these psychotic symptoms. So whenever we see these symptoms, it is saying to us that we need to ensure that we do due diligence and we need to check everything.
Wow, interesting. Yeah. Next question is, can Valium be given with haloperidol or largactil at the same time?
Okay, so we have a little pet peeve about Valium because it can become addictive. We do use it because we use it in the acute management of the agitated or the aggressive patient. It is really not the best drug to use, but sometimes it's what we have available, because Valium because it is mainly given intramuscular, and I'm sure this is what the individual is speaking about. It is given intramuscularly, and it is not very predictable. So the person may get sedated right away, or it may take a long while, or it may never happen at all because of how intramuscular Valium works. So we really don't advocate to give Valium unless it is in the emergency setting because of the addiction potential. We are also very careful with largactil as well, because as I mentioned before, largactil a very good drug because it causes sedation, but it also causes hypotension. It can lower your blood pressure, so the hypotension it's orthostatic hypotension, as well as it can affect the heart, so it can cause arrhythmias. Also, largactil can cause confusion. So depending on the age group, depending on where you're using it, we have to look at all the side effects, and we have to see, is this medication warranted at this time?
Okay. And a final question, what are the usual outcomes for the schizophrenic and the family scenario? That's from Dr.
All right, that's a very loaded question. All right, so what we always say is that if we are able to prevent, then the outcome is going to be good. But if we're not able to prevent, early intervention becomes very important. And early intervention doesn't speak only about medication. It speaks about getting the psychoeducation. It speaks about the psychosocial impact that we can have. So it means talking to the family, because sometimes the intervention may be looking at how the dynamics, the family dynamics. Sometimes the intervention may be because this individual may be using substances. So the outcome is going to be dependent on what is happening. So remember, we spoke about the biopsychosociocultural. So all of these, how do they impact what is happening in the individual's life? And if we are able to deal with those situations, those triggers, then it would we are much on the road to recovery. We also have to remember that the age of which the individual starts having these symptoms becomes very important as well. The earlier the age of onset, it means that sometimes the prognosis is not very good, especially if they are not getting treatment quite early, because in this individual will not have had the social interactions, would not have benefited from finishing school and having the qualifications to move on to various jobs or various occupations. And so they may not be able to contribute very, very well. And also the cognitive decline from repeated infections, because the younger they are, the more difficult it becomes, because most persons do not believe that they have an illness. And because you don't believe that you have an illness, and relapse is very frequent. And because relapse is very frequent, it means that you are going to have more cognitive decline. So we are looking at the whole presentation, the triggers. We are looking at the age of onset. We also look at the support. What support does this individual have? If the individual doesn't have the support needed, then you're going to find what is called a downward drift, and that downward drift presents a poor prognosis.
Wonderful.
The use of substances too, because if you're using substances, nicotine, marijuana, crack cocaine, alcohol, and other drugs, these can impact on how your medications will work. And these sometimes will send a sign that the individual is not really benefiting from treatment, or is not on treatment because you're using the substances to self-medicate. And if you're using that, it sort of has a vicious cycle. You're self-medicating, but this is also destroying how the medications will act, destroying the brain cells, and so creates a vicious cycle. So a lot of these factors interact and impact on the individual, and it will determine the outcome. So I always say to individuals that when you're looking at the outcome or the prognosis of the individual, just as though you write your history, where they look at the psychosocial or the social, the socioeconomic, so that's how you write the name, the age, the where the person is coming from. You look at how they are presenting. Are they presenting with more negative symptoms or more positive symptoms? Are they presenting more acutely ill or insidious? So the insidious onset means that they take a time to show some signs and symptoms, and that sometimes will present as a worse prognosis. Looking at their family history, looking at their developmental history. So all of these play an important part in their outcome.
Thank you so much. That was very clear, and really appreciate your responses. There are 2 more questions. If you can answer them online,
Okay.
that'd be great. And it was great to have you on AGPJ.
Thank you very much. Thanks for having me.
Thank you, Dr. Swaby, and excellent work, Dr. Foyer, and we thank you for your contribution. We are very happy to have most of our participants, and we are going straight into the thank you, which will be given by Dr. Bedesi.
Good afternoon, everyone. I have the great honor and pleasure this afternoon to deliver the vote of thanks as we bring today's virtual conference on psychology to a close. We have had excellent and practical and comprehensive presentations from all our speakers throughout the day. We trust that you have found it very informative, useful, and pertinent to the situations you might encounter while delivering much needed and valued care to your patients. First of all, let us thank God for keeping us and allowing us to meet together today as planned. We thank everyone who helped to make this meeting successful. Dr. Aldith Buckland, an executive member of the Association of General Practitioners, for the opening remarks, Dr. Donald Gordon, the president of the AGPJ, for bringing the greetings, and Dr. Arlene Henry Dawkins for the opening prayer. We would like to thank the brilliant presenters for the excellent presentations. Dr. Ganesh Shetty, Dr. Patricia Prescott, Dr. Tosan Livingstone, and Dr. Lisabeth Crossman. You all delivered excellent presentations with clarity and enthusiasm, encouraging and motivating the audience to listen and learn. And I'm sure many are more comfortable in providing care in the area of psychology. We also thank all our moderators who skillfully managed the smooth transition of this meeting. Dr. Aldith Buckland, who moderated for the first session, and not only did she moderate, but she shared with us from her wealth of knowledge. And also Dr. Raymond Notice, who moderated the second session. We also want to thank Dr. Peter Swaby for his skillful management of the question and answer segments. Many thanks to the sponsors of this symposium, without whom the event would not have been possible. Our sponsors, Viatris, which is an arm of Upjohn, Abbott International, Medimpex Jamaica Limited, Torrent Pharma, R.A. Williams Distributors, and Abbott Nutritionals, Indus Life Pharmacies and Abbott Nutritionals. We trust that we can continue our partnership with you for future sessions. We would like to thank our hosts, the Association of General Practitioners of Jamaica, for organizing and delivering another high-quality event. We also need to recognize and express our gratitude to all the behind-the-scenes technical and administrative support personnel, Mrs. Lynn Thomas Hyatt and Mr. Samuel Herod, for handling the registration, coordination, the creation, and the technology to facilitate the delivery. Another excellent job done. And of course, we need to thank all of you attendees for taking time out of your busy schedules to attend and participate in this symposium today. A huge thanks on behalf of all your patients who benefit from the lessons we have all shared and learned here today as we continue to work to improve the health of all. In the event that we have omitted anyone, a general thank you to those who may have been overlooked unintentionally. This brings today's session to a close. Enjoy the rest of your day, stay healthy, and have a good evening. Thank you.